it that should be delivering? Because we know that not everybody is receiving the best care that they deserve. The problem is improving care is not easy, right? You have changes in guidelines, you have interventions, you have innovations, you have new drugs coming up all the time. And all of that is embedded in a complex system. So the field of implementation science was born to see if we can accelerate the uptake of those evidence-based interventions, policies, practices. And the implementation research then is the study of the methods and seeing how we can improve that uptake. The goal is to improve the quality and effectiveness of health services research and care. So when somebody asks me, okay, but then what is the difference between an implementation trial and a clinical trial? I like to walk through the steps because it helps me in my head. So let's see if that makes sense to you. In clinical trials, the questions would be, would taking a drug X or would doing this procedure help a patient outcome? So we're trying to evaluate the relationship between an intervention, a process, a drug, a procedure, and a patient outcome. But it turns out that how we implement that intervention matters. So for example, take TCD screening. Would the types of training that physicians go through to do a TCD screening be different than if I train community health workers? Take a drug. Would the training or the information that I would give a physician in inpatient care be different than the information or the training that I would give a physician if he or she or they are in the emergency department? So the process by which we implement those interventions in a context matters. And there are tons of lists, there's a whole literature, there's a whole methods on trying to figure out how does that look like. So say that I have an intervention, say that now I know how to train people how to do this intervention, but play with me. What if that intervention or that drug or that process is too expensive? Or if people don't like it? Or if it's just not feasible in this particular context, in this particular hospital, and you have to go to a different hospital? Those are something that we might talk about in terms of implementation outcomes. So we talk about whether the intervention or the strategies are feasible, how acceptable they are they sustainable in this context? How costly are they? And then we talk about service outcomes. So is this efficient? Will this improve or not equity? Is this patient-centered? And timeliness, for example, in the context of emergency department is really important, right? The fun part from an implementation science perspective, not from a clinician perspective, is that context is crazy, right? So context is a moving target. It's all over the place. And those are factors that affect how we implement an intervention. So a lot of the questions that we ask is, how are those interventions that we develop fit into the specific context? And the way that we ask those questions is through examining, we call it a needs assessment, right? Examining the barriers and facilitators of the hospital setting, say. So for example, say that I have a drug. I might examine whether physicians and patients know about this drug. Say that I have a drug and physicians and patients know about it, but they are not motivated to change whatever regimen that they have. So I might examine motivation. Say that they know they really want to change, but they don't have opportunity. They don't even know how to do the prescription. They don't know how to get it, whatever barriers or facilitators there might be. So what we do is we examine barriers and facilitators, the context at multiple levels. We think about the individual levels, things like knowledge, skills. Do people have expertise to do this procedure? At the group level, coordination, how are physicians talking to each other? Organization level, is the hospital set to do this? And at the system level, how about reimbursement settings? So from an implementation science lens, we go through all of those pieces, some studies more, some studies less, because all of them affect the relationship between the intervention and the patient outcomes. See, there's this blue box called context in there. And those boxes, all of those pieces are what we do as an implementation scientist, which is super fun to collaborate with, because then I get to ask complex questions and my physician friends go like, I don't know. So let's see a case example. You guys have talked about the Sickle Cell Disease Implementation Consortium, and I will say I'm coming through this, as I mentioned, as an implementation scientist, right? So the consortium was born to improve the health and well-being of teenagers and young adults in sickle cell disease. We are 8 academic sites, and so this is a site from describing the consortia, and we have 4 working groups. You will hear Jane talking about the care redesign, the MESH study, and the goal of that study is to improve adherence to HU therapy. I don't know how to say the name. There is an ALIGN study, which is in the context of emergency department to improve the management of vaso-occlusive episodes. Then there's an unaffiliated working group, which your site is actually leading, to define what is an unaffiliated sickle cell patient, identify the strategies, and bring them back to connect with care. And there is a registry, which is the goal is to enroll several patients so then we can follow through and help address management of sickle cell disease. So I'm going to talk really briefly about the ALIGN protocol. I'm not one of the PIs, but I got to have the honor of playing with the PIs and thinking through the science of implementation science. So for this protocol, we know that there is a challenge in dealing and managing pain treatment in the context of emergency department with sickle cell disease. There is an intervention, the individualized pain plans, the IPPs. The quality gap is we have studies showing that for little kids, for pediatric patients, IPPs help having fewer hospital admissions and improve pain. Physicians like it because they know what they need to do. So it's a good overall intervention. But there's not a lot of data in the context of adult patients. So what we are doing is we're assessing how the IPPs can improve patient and provider outcomes. Would it help? And here comes the implementation science, right? So we're examining the reach, adoption, and I'm going to go through this implementation of the IPP and whether their organizations are fit to support this particular intervention. So this is an example of IPP. You have then a specific set where the physicians write the genotype, the individual pain plan, the name, and the contact of the provider, and then other aspects if they want to. So the study is from the provider perspective, the providers write the IPP. We show, the study coordinators who are amazing, show how to see and read the IPP in their wallet card and in their mark chart to the patients. During the ED visit, then the idea is that the patient would show the IPP to the providers, and hopefully that will help manage the relationship between provider and patient and help manage the pain episode and et cetera, and decrease the length of the visit in the emergency department. And then we're doing the assessment of whether that works or not. So from an implementation science perspective, we got to ask our providers, fine, you want to know whether the IPP works or not? Tell me, what is the theoretical perspective? What are the theories and the constructs that you're evaluating? And it took us a lot of conversation. And here are some of the theories that we're using. So we're using the technology acceptance model, meaning, is this my chart and is this pain plan, is this useful? Is it easy to use? Would it increase then the intention to use so then people can use it? And here's tons of boxes. where we ended up in our study. So I'm going to go really brief because I'm running out of time. But the idea here then is that as an implementation scientist, we ask questions around the determinants. The determinants are things that we think affect the ability of that intervention to be uptake. So for example, we in the intervention characteristics, we ask questions around, would the design of the IPP matter? Would the IPP have a relative advantage compared to what people have right now? In the inner setting, we would ask questions around how would the organization change or not, depending on how we implement this intervention. Patient needs and resources in the outer setting, individual characteristics. We're asking a lot of the patients around whether they like it or not. Do they know about IPPs? Do they know if this is important or not, etc. Why are those important? Because then we map the strategies. So the strategies, remember, are the how to implement an intervention. So we're examining how can we facilitate at the patient level the use of IPPs. So we teach them how to download and install the patient portal. There is a video, there's a wallet card, there's a communication script to help them talk with their providers when they're in the emergency department. At the provider level, similar thing. We have training videos, we have PowerPoints, and then we train the providers to see where are the IPPs in the electronic health record. The idea then is that in the terms of mechanisms, we have a credible source of the IPP, we have an intention to use of the IPP, and hopefully more likely to use them in the emergency department visits. All of that then affecting outcomes. So out of the number of people that come to the emergency department, how many patients are using it in terms of the providers? Will this affect the quality care that they're receiving in the emergency department? Will this hopefully improve sickle cell disease in this particular context? So super fast. How is then implementation science coming and reading how we can think about studies in the context of sickle cell disease? The first thing that we always do is examine the quality gap. What is it that's happening right now at the multiple levels? We then identify the strategies. Again, multiple levels, hopefully based on theory as well. Selecting a theory, a conceptual model, because that will then help us evaluate and measure the outcomes. Here's a list of resources for you. So the first link is a video that walks actually through the steps of an implementation study, which is amazing. The second link is tons of resources from the University of Washington in terms of what does an implementation science study looks like. The third one is our site talking about toolkits. And then you have tons of other things in terms of also sample of grants and how to learn about implementation science. I do want to acknowledge Allison King, Jane Hankins, and all the team, because I am learning a lot about sickle cell and about all the complexity that it is to support a disease. And any questions?
Thank you so much. I learn something every time I listen to you. Appreciate it. And thank you for your, and you have learned a lot about sickle cell, even though you.
Sickle cell, yes.
So one of the things that has come from this project has been increased interaction between sickle cell docs and patients and the implementation scientists. Mm-hmm. Have you seen in other fields something like this happening? And how long does it take to really get the implementation science embedded into a field? Is that another 17 years?
Hopefully not, right? So I like to preface, this is a fantastic question, and I would love, maybe that's a debate paper for us to write, right? Because the field of implementation science, remember, we are in the 20, maybe 15-year-old. right? So the classic in all of Proctor's paper saying, hi, there's this thing called implementation outcome is 2009. And it was born in the context of mental health. So,
yeah.
right? So then to your point, there's a lot in the context of mental health. It has a huge uptake in the context of HIV. HIV, I think, is one of the fields that has advanced the most. Cancer. And then we have other fields that haven't even heard about sickle cell implementation science. So let's say that we are in the toddler space.
Okay.
But hopefully embedding soon.
Great. I'm looking for whether there's any other questions right now. Don't see any in the box for Q&A, and I can't tell whether anybody's raising their hand. So let me see if there's one more thing, anything else.
I don't think we have any questions in the chat.
So maybe can I get to ask a question?
Sure.
That I would love to hear about your perspective in terms of how, as a physician, I know that we've had many conversations, right, in terms of, oh, this is painful, and when I collaborate closely with other physicians from other contexts, this is because it's a shift in thinking, right? It's a shift in thinking at multiple levels. So what have been any of the things that you've learned?
Yeah, for me, it's been like, oh my goodness, where has this been all my life? How come we didn't before? Where previously we had assumed, I as a doctor had assumed that, oh, if we get a paper published in the New England Journal of Medicine, it's a phase 3 successful trial with statistical significance, which is what the TCD stop study was, or the hydroxyurea study was, that boom, magic would happen and everybody would do it. Mm-hmm. And come to find out that that's not the case. But then I was completely stuck on how to solve these problems and stuck for a couple decades with low usage of TCD, with low usage of hydroxyurea, low trust, not good ways to communicate. So having the tools and finding out there's people who can make stuff maybe not magically happen, but at least rational, and empower patients to be stakeholders and have input has been super exciting. And so at this phase of my career, this is what I really like to do. And especially in low resource, that both in downtown Chicago, in rural Nigeria, in different parts of Brazil. This is all.
Let's go to Brazil. Yes.
You can make the most of whatever resources you can get, so you don't waste them.
Yeah. Yeah. Thank you. Thank you for that.
Thank you very much. Thanks for the questions. Thank you so much for your presentation. I'm going to move on to our next presenter, and so that will be Dr. Jane Hankins, and I just lost my screen with my notes, but she was educated in Brazil also, got her MD degree there, and then did her training in Tennessee with University of Tennessee and with St. Jude, and has been at St. Jude as a distinguished member of the St. Jude community, working on sickle cell, working on hydroxyurea, adolescent transition, has some landmark papers in these areas, and is now also has many responsibilities for the clinical care of adults in addition to the children, so with the Methodist hospital system. She's going to share with us about the project that she's been the lead investigator in the SCDIC program, Mobile Health Solutions. Dr. Hankins.
Thank you, Dr. Su. This is a great pleasure, and I enjoyed listening to my colleague and now friend, Dr. Anna Baumann. So here's your second dose of Brazil today. So I am going to share my slides. And I think one of the things that you will appreciate about what I am going to talk about is that it's almost like a continuation of Dr. Bauman's presentation. And what I try to do here is really apply a lot of what Dr. Bauman presented in a different case study, which is the use of hydroxyurea. So thanks again to Judy, Victor, Louis, for inviting me today. It's been a pleasure to working with all of you. So I'm going to talk about the mHealth solutions and specifically an app that we developed as part of this project. So these are my disclosures, my research funding and my consultancy fees that I receive. So I'll briefly talk about why should we care about hydroxyurea? Why are there barriers to using hydroxyurea despite the fact that we know so much about the benefits of this drug? Why should we think about using mobile health or an app to help address those barriers? And then I'll give you a little bit of results. We don't yet have results just available for this study, but I will talk about what COVID did, and that relates back to what Dr. Bauman was talking about, the role of the context. So sometimes we can plan for the context, sometimes we study the context and we understand and we develop our strategies, and sometimes context just happens and we just have to understand how it impacted, and that was the case of COVID. So why should we care about using hydroxyurea for people living with sickle cell disease? It's because it works. It's one of the oldest drugs out there. It's the one that we've done the most amount of research, and we understand the most the benefits and side effects and toxicities, short-term and long-term too. So we've used for decades now, but we know that increases the fetal hemoglobin, which is a hemoglobin that doesn't sickle inside that doesn't make the red cell sickle. It decreases inflammation in the bodies of people with sickle cell disease, which is such a damaging thing to have, is this constant inflammation in the body. And then the clinical outcomes, it reduces pain events, acute chest, use of blood, admissions to the hospital, improves quality of life, protects organs such as the kidneys, the brain, and improves survival. So we know all of those things. And here on the right is a picture of some pills of hydroxyurea, but then the blood smear of a person before hydroxyurea and taking hydroxyurea, the dramatic change in the red cells, and now we see fewer sickle cells and more of these purple big cells that are full of fetal hemoglobin. Unfortunately, despite the fact that we know so much, it's not reaching the patients for different reasons. So here in this chart, you will see a compilation, a pooled analysis of different publications, a few years old now, but what it's showing here is that if we compiled a lot of administrative data, shows that over 8,000 people with sickle cell disease, children and adults, a lot of them, or less than half, are prescribed in first place. And then of those, fewer actually initiate. So you're prescribed, but they don't fill the prescription. And if they do, you look at adherence here, using the medication possession ratio as a surrogate for adherence, the adherence is pretty low. So very quickly here you see, well, there are problems at the system, the provider level, and there are problems at the patient level. So there are barriers at different levels. So you can address the low use of hydroxyurea if you just focus on the system or on the providers or on the patients alone. So it's not always about, the patients, and that's the point here. You have to pay attention to the multiple levels of barriers. So how do you begin addressing it? We do what Dr. Bauman said. We start examining the quality gap. So we have to ask this question: why aren't patients being prescribed hydroxyurea? And if they are, why aren't they using it? So this is how we started. This is how we began addressing the barriers that we also call the determinants. So the determinants of poor use of hydroxyurea among patients and poor prescribing among providers. So then it turns out, and how did we do that? So this was a long process. We looked at literature, we collected data, we talked with our colleagues, we interviewed people, we interviewed patients, we interviewed providers, administrators. So we took a careful and robust investigation of everything that could be affecting the use of hydroxyurea in general. And then we boiled down to the things that were more salient and the things that were more prevalent as determinants, or here I'm going to focus on barriers more than facilitators. And among patients was, I forget, take my medicine, my self-efficacy and thinking that I am able to do it is low, my knowledge, attitude, and motivation. So those are like the ones that arose as most important among patients. And among providers, self-efficacy, a lot of providers still don't know how to prescribe hydroxyurea. And, you know, as the hematologist, you probably appreciate that, but I've had people refer to me taking hydroxyurea 3 times a day or 5 milligrams per kilo per day. So this things still exist. And cognitive knowledge also has to do with self-efficacy. So again, I don't know the guidelines to follow. So what we did first was we sit down with our team, patients and investigators, and we spent an entire day looking at those determinants and trying to think together about solutions and strategies. How can we begin addressing those determinants? And we went over the determinants again as a group. So this is a design thinking session that we undertook that was in November 2017. And we had a lot of things on the board and stickers, and what they were, okay, we look at the determinants, we look at the barriers and facilitators, and how can we address it? So for example, habit, how do we create habit of taking a medicine? And then at the end of the day, we realized, you know, we need to take advantage of technology, and how do we reach people and how do we reach providers? So everybody uses a phone. Here's a picture of one of the investigators showing the patient cell. This is an app that I use for to help track my health. So we realize, you know, will be advantageous for us to take advantage of technology to package everything that we want to do to target those determinants. And that's what we did. We started thinking about packaging interventions that act on all those determinants. So we would say, okay, we need reminders to address forgetfulness. We need to mobilize social support to change attitude and motivation. And that's at the patient level. And at the provider level, we need a decision support to help the self-efficacy among providers. So that's how we started. So we started thinking backwards from what the problems were. And then we had, and then it didn't come out of the blue that was, okay, let's develop an app. We had preliminary data and some prior work that showed that technology could be beneficial. And this is text messages, not really an app, it's just sending text messages that we demonstrated that if people used text messages, their medication possession ratio or their adherence improved. And as their adherence improved, so did their fetal hemoglobin. And this is the more they used the text, the more they received the text messages. And tell me, then they liked it. We also had a little bit of qualitative data here. So this is the product of many, many months of working together. And we packaged all the interventions into this app. This is for the patients, called the In Charge Health app. It took many months, but we did together with the company that developed the app, the investigators, and the users. And this is those are the screenshots of what the app does. So I'm going to highlight a couple of things here. So one are the reminders. Just like a text message, but not really a text message. You design your message, but then you can highlight the name of the medication, the dose, and you design, you know, whatever time of the day you want. You want it to come multiple times to remind you. And then you can track your adherence. You can say, I took it today, and you can track your pain. So then you can make the correlation between I'm feeling better, my pain is improving as my adherence improves. And then you, to address the knowledge, then now you can click and learn about side effects of the medication. And then here's you track the health trends. So this is over time, how my adherence is correlating with my pain level. And then I didn't show here, but we have the buddy system here that you can, that if you don't take your medicine, you don't mark you took your medicine for more than 4 hours, that kicks up to a person that you designate as my social support, who will then remind me to take my medicine or ask why didn't I take it, or are the barriers for me to take that medicine. So this is the paper that describes how we developed it. If you want to go in more detail, but we use what we call the user-centered design, which is when you design a product with the user as part of the developer. Okay, back to where I showed before, how we were packaging all the intervention. So here it is. The intervention then is an app that does all of these things. That's for the patients. And we also have a separate app that was developed by Dr. Nirmesh Shah from Duke University here that does all of these things at the provider level. But I am going to focus on the patient app because of time. But when you have this the package of interventions inside the app that does all of those things, we hope that, for example, forgetfulness is addressed by the daily reminders, and now patients remember to take it and develop the habit. Remember, I mentioned in the beginning, how do we create habituation? And that is true for all the other determinants that we're addressing through this intervention. At the end of the day, what we wanted is just to improve adherence, to then decrease acute care utilization and improve quality of life. At the provider level, we do similar things, but as I said, I'm going to focus on the patient provider. And then here on the bottom of this picture are the implementation outcomes that Dr. Bauman mentioned. So the reach and adoption, are the apps reaching the population that we want? Is it being adopted by the clinics? How is it being implemented? Does the app work the way we designed? Is it being introduced to the users in a way that they understand? And then the effectiveness in maintenance over time, as it continue to be used over time. So this is an implementation mapping, which is just what we used, and also a way to help you develop the interventions. Intervention mapping. And this is just putting together with the frameworks that Dr. Bauman mentioned, and this is the CIFR framework, and this is the implementation framework. I'm just putting this slide here just to show how everything fits together. So, for example, we also use the technology acceptance model to develop the provider app, but we use the health belief model to develop the patient app. So we use theory-driven behavior intervention, behavior change models and theories. So, and then we are accounting for, the patient characteristics and provider characteristics that could influence the use of those apps. So this is the study that we're finishing, and we're using together the In-Charge Health app for patients and the provider app. It's called HU Toolbox, and Dr. Nirmesh and I are co-PIs in this study, and it's been finalized and was conducted in 7 sites. I'm very thankful for our partners in Chicago, who are a very active site, and then in Peoria, Illinois, too, was a site for this study, who enrolled patients in this study. We have 293 patients enrolled, but I don't have final results. So I'm just going to show you the preliminary results that have more to do with COVID. So the first 2 sites were St. Jude and Duke. And they were the first 2 sites to open this study. And unfortunately, the patients were enrolled, and because we asked them to use the app for 6 months, that happened during COVID. So they got enrolled November, December, January, and then COVID hit in March. So they continued to use the app after the pandemic. Some people got enrolled in February, and a month later, the pandemic hit. So what happened was each of these two sites responded differently to the pandemic. So St. Jude had a lockdown that lasted 9 months, and Duke had a lockdown that lasted only 2 months, and they immediately switched to telehealth. So they responded differently, meaning the context for both sites was different. So the goal here is to illustrate the impact of the local context, how the response to the pandemic affected the results of the study. So there were 64 patients who were enrolled before the pandemic, and their participation in the study happened partially before, but also during the pandemic. And they experienced the lockdown depending on which site they were. So there were 64 patients, and 58 of them utilized the app at least once. So the reach was 91% approximately. And then the patients accessed the app on average 42 days over 6 months. So about a quarter of the days on the study. And 37% of those patients accessed more than a quarter of the days of the study. So those were the high users. So we had people who used a little, people who used in the middle, people who used a lot the app. And then what happened was after the pandemic hit, March 15, which was when the lockdown started in both places, there was a decreased use of the app. So the percentage of the patients who used the app decreased from 85.9% to 7.3% after the pandemic. But it varied. Some people use more after the pandemic, some people use less. So here's the chart that shows two distinct group of patients. So in red here are people who used less the app after the pandemic, and in green here is a group that used the app more after the pandemic. So you asked me what's different about these two groups. We looked at several different factors at the clinic level, at the patient level, and the thing that was the most important in influencing the use of the app was how long the lockdown lasted. So how long did you experience the lockdown from the time you enrolled on the study and started using the app? How long until the pandemic? And then during the pandemic, how much lockdown you experienced? So that was the main influence. So for example, if you had 14.7 days of lockdown, you were 33% less likely to use the app. Whereas if you had 25% of lockdown time, you were 50% less likely to use the app. So that clearly demonstrates that the duration of the lockdown influenced how we use the app. And how did that influence the adherence? Well, we did influence. So the first site A, had a lockdown of 2 months. Well, those people had improved adherence. They at 12 weeks improved by 20%, and then at 24 dropped a little to 16.7%. Site B, the lockdown was longer, the adherence actually decreased. But if you use the app more after the pandemic, and that happened in both sites, your adherence improved. So this chart here on the right shows a change in the app use. So the more you increase the use of the app after the lockdown started, the greater your adherence improves. So if you look here, there's a trend going up. So this is the multivariable model that shows your baseline adherence also is important. The lower you are when you begin the study, the more your adherence improves. But the more you use the app after the pandemic started, the more your adherence improved. So after the start of the pandemic, if you use the app, that really helped the adherence. So that was a good thing. And the qualitative data supports us. So this is a mixed method analysis that we did that shows in both sites, despite the fact that there was lockdown, they were distant from their providers. In site A, it made them use hydroxyurea. They say, it helped me. But in site B, where the lockdown was longer, they said it helped me, but it was so hard because the clinic wasn't open, and it's hard to get to my provider. So they clearly stated, the barriers of the change in the context. So in conclusion, low hydroxyurea utilization happens due to multiple level determinants, and it's important to develop intervention that is tailored to those determinants. And intervention mapping is what we use here to help develop this intervention. Implementation can be affected by the context, like Dr. Bauman mentioned. So it's really important that you account and try to understand it, in which ways it influenced and why. And the good news is that mobile health, it can be beneficial to increase the hydroxyurea adherence despite those contextual influences. Where we're going from here, we're now analyzing, we're finishing the data entry for the study, and we're going to analyze now all the 7 sites together, and what was the change in adherence, and how much did the app influence the change in adherence, and what did the context of those other sites change. Chicago had great needs assessment analysis that showed us a lot of things about how do we introduce the app, or the features of the app that are probably not helpful. Some are, some aren't, and how do we make this better for the future? So thank you. And I think we have maybe a couple minutes for questions. Sorry, I went over.
Oh, great. Thank you so much, Dr. Hankins. Thank you, Jane. We do have a couple questions from Shanita Clark. I'll read them. What is the current plan to extend the app to other states? And what is the current plan to increase healthcare providers' knowledge to increase the use of hydroxyurea?
Thank you, Shanita. So the plan is to make it available to anybody. So actually, the app is in App Store and Google Play. We would like to finish the analysis before we say use it, because I think what I'm starting to see is that I think it may not be beneficial for everybody, and I don't know how long the benefit lasts. So there are some unanswered questions that I'd like to answer before we say anybody who wants it can use it. So then it's better informed, because apps, the thinking today is apps are like medicines. You can digitally prescribe an app, and not everybody responds the same way to all the medicines. So it's just the same thinking here for apps. So if I could ask to wait a little bit longer, let us finish the analysis, then we can share with everybody. And for patients, the same thing. So for I didn't talk about the provider app because I didn't have enough time, but the provider app has a lot of features to help increase the use of hydroxyurea. But what we're finding is that the providers who use the app knew a lot about hydroxyurea already, so it really didn't help that much. So we would like to test this provider app among people who don't know as much, who are not hematologists, they're not experts, who actually could really use the app and learn and use that as a decision support.
Great, thank you very much. Any other questions?
I do have a question. The question is related to how much is factored in when you're thinking about physicians prescribing it. I know I'm a nurse and I work on the floor, and a lot of times physicians, because it's traditionally used as the chemotherapy drug. So if you are like typically on a med-surg floor, if the nurse is not chemotherapy certified, they wouldn't administer it. And so, yeah.
Oh,
Wow.
That must be institution specific. So my institution doesn't require the nurses to be certified to use hydroxyurea. I think it's a conversation with the administration, the nursing leadership, because you don't need it. You really, I mean.
Well, typically, I mean, I'm a travel nurse, so I've seen this happen across not just one facility, but multiple facilities, not at all facilities, but I'm wondering how much of that is a barrier. You might have even just some, like the Herceptin 2 drugs that this happens to, not even just hydroxyurea. So that's the thing.
I did not know about the policies in some institutions that was a barrier, but I can see that being a barrier. I mean, you just don't allow people to give the medicine, but that's inpatient, right? When if you're outpatient, that shouldn't be an issue. And if this is a drug to be primarily given out. When you give inpatient patient in the hospital, you want to continue it, but the bulk of the use is outpatient.
Right. So, well, I'm just thinking if a patient is and they initiate the use while they're inpatient and then they use it while they're outpatient. So that's something I'm just thinking about.
Thank you.
All right. Thank you so much, Dr. Hankins. I think we're Oh, Bobby Lee, do you have a quick question?
Yes. Hi. My name is Bobby Lee Arnold. I'm 64 years old, and I've been taking hydroxyurea for 32 years.
Wow.
And I was wondering, have you ever thought about like having people like me who have been very successful with the drug talk to people? And then maybe, I mean, I know I'm older, and then also too, I see a lot of young people, so I might not, get through to them. But I think the app, what you're doing, is great for young people. But I just wonder if that could be a motivator.
Oh my gosh, give me your number. Yes,
Yeah.
I'm gonna hire you. Thank you.
Thank you so much for that comment and question.
Yes.
All right. It's excellent to have these kind of meetings, get volunteers.
Yeah.
So thank you so much. We are trying to keep on time. Ms. Beverly, what do we do next?
We have time. This is Patricia. We have time for a 2-minute bio break quickly.
Okay. I'll go take my bio break. Thank you very much.
We'll start again at 11:05 Chicago time.
I saw you sit on my
Hi, my name is Dorinda Lawrence Sims, and this next session too, the speakers will cover the application of implementation science at the state level. Patricia Lassie, our ISAC Research Coordinator at Mount Sinai Health Systems, will moderate this session.
Hello, everyone. Oh, shoot. Our first speaker in session 2 is Dr. Andrea Lamont, who's a Senior Research Associate at the Wandersman Center for Implementation Science.
Thank you so
Andrea?
much. Yes. Do I have access to control my slides, or will you push them forward? There we go.
I believe you do, yeah.
I got it. Okay. Thank you so much. Oh, I'm sorry. No, you could put that back on the screen. Should I share my screen with my slides, or do you want to put the other version back up? I don't.
Share your slides.
Oh, okay. Oops. All right. So thank you so much for this amazing summit. My name is Andrea Lamont. I am presenting alongside Abe Wandersman, who's also on the line, and we're presenting some work that we have done related to really bringing implementation science into practice. So we began talking about implementation science today, and ultimately the essence behind implementation science is to improve the way we do things in clinical practice. And so that doesn't just always happen magically. We have to take specific steps to bring implementation science into practice and to really think about how we take an increasingly growing body of literature and make it practical for the end user. And this is what we're going to talk about today. This issue of how do we take evidence-based programs to improve sickle cell care is an important question. But there's an extension of the question of how do we take evidence-based programs and make them work for us, for the people in Chicago? How do we make an evidence-based program work? We often talk about evidence-based programs being necessary in order to improve care, but they're not a sufficient condition. So what can we do to make sure that when we take these programs that we know exist in the clinical literature, how could we take them and move them into clinical practice in a meaningful way so that they address the context within which something is being implemented? And at its core, this is what implementation science is, but we really need to move it beyond just implementation science in general into something much more specific. So this is the overview of what I'm going to talk about today. We're going to talk about implementation science versus implementation practice. These are two worthy bits of information. Then we're going to talk about readiness building systems. And I'm sorry for my, this is the life of the working mom. We're going to talk about readiness building systems, which I call a Cliff Notes version of implementation science. This is how can we take the science that's out there and synthesize it into something meaningful and small that people could digest and the end user could use. It's similar to thinking about an entire clinical literature out there and expecting every single doctor out there to know every single piece of clinical literature. We need to distill it to something meaningful and translate it. And that's what readiness building system is for implementation science. And then I'm going to talk about how this readiness building system helped improve MESH for Isaac specifically. So very concretely, how we used these theories to improve practice. So readiness is a synthesis of the science of implementation. It really refers to the extent to which a clinic is willing and able to implement something new. So for years, we have looked at implementation as a capacity issue. The question of, are we able to implement this thing? So we've said, do you have the resources? Do you have the staffing? Do you have the technical capabilities to implement an evidence-based program? But what we know is that having ability is certainly not a sufficient condition. We also have to have the motivation and the willingness of the people within the clinic or the hospital setting to bring that evidence-based program to life. And so for years, implementation scientists have been saying, okay, what are the facilitators of implementation? What are the barriers of implementation? And we've accrued this massive body of literature in this area. And quite quickly, may I add, that body of literature has grown. Readiness brings it all together and synthesizes it in a Cliff Notes version of implementation science. We define readiness in this somewhat cheeky heuristic saying R equals MC squared, where readiness is the combination of one's willingness or motivation and their abilities, their capacities. And capacities come in two forms: their innovation-specific capacity and their general capacity. So what does this mean? It means that readiness is a three-legged stool. When I say readiness, people often think of the old adage like ready or not, right? And you all saw my little one who nearly was well behaved all morning until the 10 minutes that I had to do a presentation, because such is life. But when I think of readiness, it is always this notion of ready or not, right? And we play hide and seek, ready or not, here I come. And that implies that someone is either ready or not ready. And sometimes that's true. So for me, when my kids say, let's play hide and seek, my motivation is at zero, because I actually really hate playing hide and seek. The only time I really like playing hide and seek is like when my motivation is this high, and it really means I go lay in my bed and take a nap while they can't find me. But typically my motivation is really low. So in that case, I'm not ready to play, zero. Sometimes your general capacity is really low. Like my little guy here a couple of years ago, he couldn't walk around the house. He couldn't play hide and seek. He was crawling. He was a baby. General capacity low, ready or not, dichotomous construct. Same with innovation specific capacity. These are the capacities that you need to do a specific innovation well. At that time, when he plays hide and seek, he hides in the same exact spot every single time, and my 8-year-old finds him every single time. He doesn't really have a very strong innovation specific capacity. Ready or not, dichotomous construct. When Abe, I, and the rest of our team came up with this heuristic, we said that is not sufficient. That doesn't work, because when you think about bringing in innovation into a hospital or clinic setting, it's so much more nuanced than that. You might have varying levels of motivation. You might have varying levels, and your general capacities may change over time. Heck, the general capacities of hospitals was deeply affected during the pandemic. It doesn't mean you're not ready. It just means you need to build readiness to become more ready in a specific condition. And this is the spirit of which we target implementation in Isaac. How can we take these buckets, motivation, which is comprised of these different subcomponents, innovation specific capacities, which is comprised of these different constructs, and general capacities, which is comprised of these different constructs, in order to build motivation. So it's not the sense that you're either ready or not, but rather in which specific areas might your readiness be affected, and how can we build that readiness over time? I'm going to say that again because it's a really important point. In which ways these very specific subcomponents, these very specific areas that are facilitators and barriers of implementation from implementation science, how can we observe them in a setting, and notice our patterns, notice the areas that we are lower in, and use that information to improve readiness and therefore improve implementation. So I don't have time today to go into every single one of these subcomponents, other than to indicate that these are the major facilitators and barriers delineated in implementation science and put into one nice package. So how did we use this concept to improve readiness in MESH? Well, I will say that the Isaac team took this very seriously, notably seriously, and it was so refreshing. And what it really took was a commitment to be curious and explore the different ways in which bringing an evidence-based program into Chicago, what it might look like, and how we might need to change the sales, adjust our sales a little bit. And so weekly, a group of investigators and coordinators met on a weekly basis, and we just went through this very specific conversation about each one of those subcomponents I showed on the previous slide, and which areas we had strengths in and which areas we had weaknesses in. This all started, these weekly conversations really started with a willingness to improve, to turn that lens on ourselves and say, in what areas might we experience an implementation pitfall, and how can we improve that so we don't hit the pitfall, but rather we plan accordingly. So this was the readiness thinking tool that we went through. It's obviously much longer than this. These are just snapshots, but you could see that for each of all of the different interventions in Isaac, MESH included, we looked at each of the subcomponent indicators, and we talked about, for providers, what challenges may arise and what strengths do we see related to this subcomponent. And the same from the patient's perspective side. And we elicited some feedback from our patient advisors as well. And this took a couple months' time, right? These really detailed conversations, and they led to this beautiful summary of very specific strategies and adaptations that could be made to the MESH project, so that when we brought MESH into Isaac, it was done with high quality. So simple things and surface level things, from how do you download the app and what if you have an update on your phone, to bigger picture things like what resources are available in the library and are they meeting the needs of various different subpopulations. How do we use notification features and how do we roll it out and make this a meaningful experience for both providers and patients? These conversations were really invaluable to really thinking through the details that are necessary to implement this program well within our setting. So the key takeaways here is that implementation science in general is not designed to be a program of research that just sits on a shelf somewhere. It's not designed to just accrue knowledge for knowledge's sake, but it's really designed to be very practical. And that practicality does not just happen with a little bit of, magic wand throwing, but rather intentional systematic effort. And that is really what readiness provides. Readiness provides a very pragmatic solution to take implementation science and bridge it over to implementation practice in real world settings. And we could use implementation practice to actually improve the programs that we are implementing within Isaac. And my last key takeaway is really an emphasis on how seriously the Isaac team took implementation and this improvement focus to the programs. This summit is about a collaborative journey between patients and physicians, and the amount of work that they placed in this, not just to bring evidence-based programs to the Chicago area, but to deeply consider the patient needs and how these programs fit with and are compatible with the patients and communities, in the surrounding area, is really notable. These are not just we sit here today and we talk about programs coming in, and what you don't see is all the work that went on in the background. And so I commend everybody on the Isaac team and the patient advisors for taking this so seriously, because you really are the cream of the crop when it comes to implementation and the quality of work that comes out of it. Does anyone have any questions?
You may unmute yourself and ask a question directly, but I don't see any in the chat.
I don't have a question, but this is Bridget Reynolds. I just love listening to you talk on implementation science. There is such a wealth of knowledge that comes from the Wondersman Center, and the knowledge that you give can be used in so many places in our lives besides just here at Isaac. So I really enjoyed that presentation.
Thank you so much. You know, I thank you all for being patient with my 3-year-old who felt the need to be part of it as well.
Yeah, good job, Andrew.
Thank you for
All
joining.
right. Thank you so much. So our next speaker is Dr. Joseph Kola, who is an associate professor at the University of Illinois Hospital and Health Sciences System.
All right, Beverly, you're going to have to help me make sure I get this on the right mode. I am in scrubs because I'm out in rural Illinois and I just got off of a 24-hour shift. Usually not that busy out here, but we had a couple late night patients. And break out here, although at least none of the patients are having, you know, the bad respiratory stuff, but just a lot of visits. So I'm going to share my screen, and if I share it the wrong way, I'm going to stop and reshare it real quick. So desktop, okay, share, and then pull this up, play from start. Is it showing you the?
It's good.
It's good?
You're good.
All right, let me minimize so I don't see my rugged face while I'm doing this. All right, so I'm going to talk to you, I have 10 minutes. I'm going to talk to you about my experience with the individualized pain plans that we implemented for sickle cell patients in the ED through the ALIGN study that Dr. Baumann talked about. Here we go. So I'm going to spend just a few minutes, like 1 or 2 minutes, just talking overview of IPPs, sickle cell, the SCIDIC consortium and the ALIGN study. And then we'll show you some preliminary data just from our local shop with regard to ALIGN. And then we'll discuss our plan moving forward. One thing that makes this much easier giving this presentation after a long shift is that I'm here with all my friends. I mean, I meet with most of you every Tuesday, so I know you won't judge me too hard. Okay, first section. So individual pain plans weren't a unique idea. Lots of, even back when I was in residency back in the early 2000s, we had like a paper book with individual plans for sickle cell patients. But it wasn't until 2014 that the NHLBI actually made it a formal evidence-based recommendation. Both for adults and children. Just to overview about SCIDIC. SCIDIC is one of the most funded, largest collaborative efforts for sickle cell in the history of Western medicine. It has 8 powerhouse sickle cell centers, including us, and just a lot of great minds on it. Now, the whole goal of SCIDIC, which was funded by the NHBL, was to identify and address the barriers, both the barriers for the provider and of the patient for better care for sickle cell. And to do so, they first wanted to develop a registry, which I think somebody's going to talk about. And then they conducted needs-based assessments with all of our implementation scientists, and then designed 3 really cool studies. And the studies and you'll hear about some of these, is the redesigning outpatient care, addressing unaffiliated sickle cell patients, and near and dear to my heart, the improving ED care. Our needs assessment for the ED portion of it showed that out of sickle cell patients, 70% use the ED, but only 40% are really satisfied with their experience. And out of the out of those that use the ED, 70% admitting putting off going to the ED because majority is because they just had a bad experience or didn't feel respected. Hence the ALIGN study, which is this ED arm for SCIDIC. So you saw this slide before with Dr. Baumann. I'll just kind of overview it again. Is that first the patients enrolled, it's selected. I'll talk about that in the next slide. And then the patient and the provider come up with a plan. The provider proposes a plan. The patient says, yep, that's going to work for me. And then they publish it on MyChart, where it could be both accessed to the patient and the provider. And then when they go to the ED, immediately afterwards, we send a survey to both the provider and the patient, and we analyze the data. In addition to that, we do individual interviews and we get some qualitative data as well. So seems easy. but it wasn't. And that's part of the whole implementation science, which I've learned to respect through this and love during this study, is that this went very not well in the beginning, which I'll address in the questions, but I have to keep moving. So basically the patient is screened. In order to be enrolled, they have, and by the way, I don't have the provider view on, so if I'm getting close to going over, please just let me know. But the patient has to have had a recent ED visits and had to have been followed by a sickle cell provider within 12 months. If they were, then they were eligible. And then we got baseline survey for them to see what their kind of experience was in the ED. And then the IPP was reviewed, it was downloaded, and then once that patient that has an IPP goes into the ED, that is considered a qualifying visit. And then, we follow that 9 months out. So each institute was tasked with getting 40 surveys. Now, this was kind of put on, really hit hard by the whole COVID thing. We fortunately were able to get 45 patients enrolled. We met that goal, and a qualifying visit has to be an individual patient that has a survey. So we had 31 patients actually from the 45 visit, and 27 of them we got their surveys from. On the provider side, we enrolled 100 providers, and 38 of those 100 providers saw a patient with an IPP. So there's 38 individuals, and then some of them had 2 visits, 3 visits where they saw other patients. And then we took all this data, and that's what I'm about to kind of go over. So most of the patients were SS, which usually considered the more severe type of sickle cell. The median visits per hospitalization per year were 5, and the median ED visits were 4. There was a disproportionate amount of males, and I'm not really sure why that is. And total of the 42 patients. It's actually 45, and that was an older slide. So this isn't statistically significant. This is just our local shop. We're going to combine all this data. But in general, the patients became more satisfied with after the IPPs were in place. Now on our interviews, this was much more strong. There was a slight more improvement with low utilizers versus high utilizers. And I really think that if we would have done, I'm interested to see this. I have a hypothesis that later in the study, I'll bet you this experience was better, because in the beginning, people just, when patients were presenting, the front desk and the triage just weren't looking up the studies. I was getting literally called at home on my off hours to call into the ED to tell people, remind them about this. This took a tremendous amount of education, just so you know, of the providers. And it took a long time getting used to, and I'm sure the implementation people have a lot to say about this, of getting used to having these. One thing that is not surprising is that when the patient felt that their pain was addressed better, that their overall satisfaction was better. Now, this is what's interesting. Even though we had a positive response from all of the advocates and sickle cell patients, you really didn't even make on a lot of these patients the door to dose in the first hour or even 2 hours. And just having these IPPs still improved the satisfaction of both the patient and the provider, as you'll see. So much so that most of the patients said they will definitely, that they will use they strongly felt that they would use their IPP next time they go to the ED. So as far as the providers, 100 of them, it was pretty evenly split between male and female. There were 41 attending physicians, 48 residents, and 11 advanced nurse practitioners. We included the nurse practitioners. This was actually something we had to debate, because they often serve as the triage first person that a patient will see. They start the orders and put the first dose in, and that was important for us. Generally, it's not surprising. Well, this part is. This is the difficulty finding the IPP. So this was the only bit of that was kind of all over the place, both, and you'll see with the nurses as well, is that in the beginning, everyone, after I gave my speech, introduced the lecture, did the baseline surveys, everybody was able to find the IPP, but as months went by, I had to reinforce where it was, because I would get emails and calls like, I can't find the IPP. This is also something we're working on in the future, and this is one of the things that's come out of the implementation science of this. So providers were very likely to use the IPP again, and they intend to use it all the time if available, basically. So moving forward, the question is, and this came up in our collaboration, is, well, can we, clearly the providers like it, clearly the patients like it, at least that's what we're getting. We'll find the definite data where it lands once we analyze it all. But so is it possible to get IPPs for all sickle cell patients? So we decided in order to do that, we need a full-time coordinator, which is going to cost money. So we have to do this wisely. We also are currently working with our IS department to make the IPPs more accessible. And this time, one of our greatest mistakes, and I've said this from, when we first started using the IPPs, one of our biggest mistakes was not enough buy-in from the nurses. It's something I really regret. We've debated it a lot at the national level even, and made it an optional intervention. And in the future, I really do think this should be a mandatory. It's even more important, I think, than the docs. So I did get a chance, and this year, the first to see this data, I sent out a nursing survey. This is my first step in trying to get the hospital to fund us a coordinator. Is I sent out 5 questions to the nurses. About 22 answered. I'm going to resend it out. I'm hoping to get at least 50. And basically, out of the past couple of years, it says 5 years, but really the first IPPs weren't being used until like 2018, 19. In the past 5 years, did you ever use, or were you aware of the IPPs? And most of them were either aware of it and used it, or aware of it and didn't use it. Again, how easy was it to find is kind of all over the place, because it was not we did our best. We switched over in the middle of the study, by the way, from Cerner to Epic. So that was a challenge. It was a challenge to to inform and educate the providers where these were. But this was good that most RNs, did find it very helpful. Verbally, I got a lot of positive response. And they felt that it improved the experience caring for sickle cell patients. Now, this is not statistically significant, but it's a first step. This is a slide I kind of regret making it so small, but this was having the nurses check why they liked it so much. And the number 1, 2, and 3 reason was that it sped up. It was, 1, less conflict with the sickle cell patient, and it resulted in faster dispositions, either to admission or not, and we have boarding issues, and improve the efficiency of care for the patient. A lot of nurses specifically said that they could actually spend more time nursing instead of like double checking if this is the right dose. And then way down the line, the nurses just felt more comfortable giving large amounts of narcotics when they had the backing of a sickle cell provider and an attending. So basically, next steps, our next step is to go to the nursing leadership, present our data, make our case, and then eventually work our way up to ask for funding for a coordinator. We're also working currently, this is an active thing, with the information system team to make the IPPs more of a flag, something a bit more visible that you don't have to search for, and continuing educating the nurses and doctors. So we'll go with questions here. I'm sure I'll have a few. Can I stop sharing now?
Are there any questions for Dr. Kola? This is such an important intervention, I think. Oh, Dr. Kola, you're muted.
Should I check the chat for questions, or?
We have one from Bobby.
Yes, hi, doctor. I'm sorry, where are you located, sir?
I'm at UIC, but right now I'm at I moonlight at a rural hospital. I couldn't get out of the shift. So my boss let me use his office to do this presentation.
Okay,
and I'm still in my scrubs.
I'm a sickle cell patient as well as an RN myself. And I'm stunned that you didn't include the nurses in this program. I mean, one of the things that nurses complain about, they're horrified of the amount of drugs they're giving patients. So I'm just absolutely flabbergasted that they weren't included.
Yeah, well, that's what you get when you get a bunch of docs in the room, making these plans. But in fairness, it was discussed a lot. It was more of an issue, just in fairness to us, our researchers, it was more of an issue of the difficulty with all the turnover with nurses and a large amount of nurses, of the difficulty of we notified all the nurses, but we didn't do the specific repeated information and checking their knowledge of it. And what was happening in the beginning were the sickle cell, all the nurses, we announced it to them at the meeting that this was happening. But when the sickle cell patient was showing up, they were like, and they were showing their phones and stuff. It was like, you know, even some of the providers weren't, they would forget about it, and they were busy and they weren't addressing it. So yeah, no, it was admittedly a big error. It probably would have helped things get there much quicker.
Okay, well, I'm glad you realized you guys made a mistake. So hopefully you'll correct it in the future.
Well, yeah.
Thank you.
Bridget, do you have a comment or a question? Bridget Reynolds, unmute yourself.
No, I didn't. Did my hand get raised by accident?
Yeah, it is.
That was unintentional, sorry.
Okay. Are there any more questions for Dr. Cola? I don't see any in the chat.
Louis Sue, thank you for the presentation. So knowing what you do now, how often would you want to do refreshers and reintroductions for staff that turn over a lot? 3 months?
Yeah, that's a good question. Definitely more than once a year, which was the plan of the study. I would say once a quarter. It doesn't have to be much. It just has to be. What I realized was that I can get a lot of information out real quick in the meetings if I have everything ready. And I think, you know, and with Zoom, I think it actually kind of helped with Zoom because I could just like share my screen and then get off it real quick without having to go up to the slideshow. And when you just announce things without visuals, people just don't retain it. I mean, those meetings get long. And remember, during COVID, like we had so much information overload too. And I think that really contributed to it as well. We're just in a world of information, and there's always a new policy coming about, especially in a state hospital. There's always some sort of new thing we're measuring, a new thing we're checking, a new thing that the state is trying. So it's really hard to keep people's attention span. So I would say once a quarter, probably.
Thank you.
Let me check the chat. All right. There's no additional questions in the chat. Does anyone else have any questions or comment before we move on to the next speaker?
Well, I'd like to say that as a CAB member, I do remember Dr. Cola discussing, you know, nursing attitudes about dosing patients with sickle cell. And I know that was a sticking point for him, and that he's worked very hard to make sure that he bridges that gap and some of the reticence that nurses have about giving that medication, that issue would be resolved. And I've heard a lot of talk about it, just so that the audience knows this.
Yeah, I was trying not to like, you know, say, but I was kind of sounding the alarms of this early on, but we were really racing against time. There were other providers. It was more of a pragmatic, incorrect, but pragmatic decision not to make it a mandatory intervention. So they were worried about the cost and time it would take to continually reinforce it, and they kind of felt like if we got the nurse leadership, which was a part of it, that the rest would follow. But I think it was an error in judgment, in all honesty. So.
Okay, thank you, Dr. Cola. Our next speakers are two of ISAC's Community Advisor Board members, Bridget Reynolds and Dorinda Lawrence, who are going to share their perspectives.
Thank you, Patricia. I'm taking talk a little bit about the community involvement with ISAC on the community collaborations level. My name is Dorinda Lawrence Sims. I'm a patient and advocate, and I am an ISAC community board member. We're going to talk about community involvement. So there, ISAC engaged stakeholders to help build better interventions. Are we sharing the slides? Did you guys?
Give me 1 second.
Okay.
You can go to slide 2. That's the one Dorinda is doing.
That would be slide 2, please, Beverly. Okay, so Isaac, here we can talk about pre-funded objectives for the community engagement in Isaac's project. Let it go back. Yes. Isaac engaged stakeholders to help build better interventions by inviting community experts and partners, engaging social workers, community health organizers, school administrators, nurses, the Illinois Department of Health, legal aid workers to discuss policies, barriers, and other system-level issues. From this engagement, the Community Advisory Board, which we consider as CAB, was created. Isaac Community Advisory Council became composed of a group of passionate stakeholders and advocates committed to improving the lives of patient families and all those impacted by sickle cell disease. The ISAC team recognized the importance of the Advisory Council. Here and on other platforms, we've been able to contribute our views, share our thoughts, stories, and contribute our input for supporting the success of ISAC. We're glad to be included in a part of this collaborative journey. Now, I'll introduce Bridget, who will talk about community involvement and empowerment. Next slide, please.
Okay, can you hear me?
Mm-hmm.
Okay. As Dorinda, I want to back up a little bit though and talk about who the principal investigators were on procuring that grant so that Isaac could be created. At the beginning, the PIs were Dr. Gorduke, Dr. Sood, Dr. Jerry Krishnan, and Dr. Melissa Gutierrez. They solicited letters of support from the community. And so at the very beginning, there was engagement. And letters of support from the community proved to be vital to the vision to become part of National Institutes of Health Sickle Cell Disease Implementation Consortium and create one of 8 national centers in the nation. Isaac would reach persons with sickle cell anemia in the greater Chicago metropolitan area to address the present state of care of the sickle cell community, improve its delivery, and thereby outcomes. Isaac history and its partnering with the community to create Isaac is a microcosm of how advocacy, being involved, being engaged, can help shape our futures and the futures of others. Next slide, please. Community empowerment. Compared to other MACs that I've been in, and I can truly say, and I believe the members of the CAP can agree with me, we have a very satisfying portion of autonomy and leadership roles. There is trust from familiarity, which does not always breed contempt, but it encourages, it supports, and energizes. We know the team knows us. We have a seat at the table, a sense of belonging, and purpose of being there. If there is something that we want to present to the team that we feel is on the minds and hearts of the sickle cell community, we can do that in the discussion, and there'll be follow-up discussion. We can write a position paper, we can create guidance documents or survey and push it out to the community through partnering, advocacy organizations, or even our community health workers. And in closing, I'd like to say that our community is diverse, and we have a great value, whatever level of education and experiences that we have. And this is to the audience, to people who have sickle cell. There is a place for us in the world of science as advocates and not simply as patients. Doctors and scientists learn and benefit from us, not simply as a means to an end, but to having the power to connect through our stories, through telling the tales of our lives, our struggles, successes, hopes, and fears. This is a necessary component to shape a better world and better lives for those of us, including myself, who would like to live beyond subsistence. So, learning from a diverse group, we have great opportunity to learn from a diverse group, which includes doctors, nurses, coordinators, and other CAB members of diverse backgrounds. study designers, people who study public health, implementation and population scientists, as well as translational scientists. In some ways, it's like school in and of itself. It is a great and rewarding thing to be a part of. Advocacy and empowerment are essentially about equity in our everyday lives. There, through simple and small steps together, we can travel miles and maybe even thrive.
Yes.
Last slide, please. And I'll let it speak for itself. Purpose is a great elixir. It inspires you and is a balm for others. Thank you.
Thank you, Bridget and Dorinda. Are there any questions for the advisors?
Hi, this is Louis. Thank you so much for your presentation and for the insights. We continue to learn from you. And thank you all for putting this together. Can you comment how much having to be in this COVID world, basically always on Zoom for these inputs, how much has that influenced your ability to be stakeholder advisors?
Well, can I say something? So I know you see Bridget and myself, but Beverly's also an advisor. She's kind of working a little bit behind the scenes today. So it's not just the two of us. Beverly is also a community advisor for Isaac. But Bridget, did you want to take that question, or do you want to?
We can share it because we might have different perspectives, but I know that you and I share the same kind of ideology about the pandemic and how we interact. So
yes,
you can go ahead first.
I feel like that Zoom has become a platform to allow me, speaking for myself, and I'm hoping for the other members. I'm sorry, I didn't also mention Maxine. I know it's myself, it's Bridget, it's Beverly, and it's also Maxine who are CAD members. And so for myself, it helped me to be able to stay connected to Isaac. And so like the Zoom provided an opportunity for me to be able to participate. I have to be present during the midst of COVID, having to come to the hospital or wherever meetings may be scheduled. The Zoom provided me a platform to be able to stay connected, get connected, and be able to stay involved in the community arena with my purpose about talking about advocating sickle cell. And so that's kind of how Zoom helped me stay connected and involved with UI Health and other platforms who welcome me to share my ideas, my opinions, and tell my story.
Right. And I would say I like to diddle that because instead of Zoom being a hindrance for people with sickle cell, and I can only talk for myself, and I see that Dorinda shares the same point of view. There are places that sometimes you can't go because of thermal comfort, and it might be too cold in the room. It may be too hot there, or extremes of temperature are an issue with people with sickle cell. And a lot of times when you go to events, sometimes even events that are for sickle cell, people don't think about the environment, and then it's cold to stay in there. So it really has opened up the door for me to participate more rather than being a hindrance.
Yeah, and I think people are kind of exhausted sometimes with Zoom. But for those of us who are sickle cell patients, and we consider ourselves as warriors, it does help. The platform is really Zoom platform has allowed us to stay connected. I can talk to, and this is just amongst the CAB, I can talk to Maxine, I can see Maxine, I can talk to Bridget, I can talk to Beverly, and not have to be trying to figure out how we're going to meet up or if we got to meet someplace or meet here, and keep ourselves safe in the midst of the COVID pandemic, which is hopefully and prayerfully coming closer to some form of a norm.
It's a little less hectic that way.
Yeah, Maxine, did you want to say something, or did you want to say something, Bev? Go ahead.
Maxine?
There are some comments from Talana you might want to touch upon in the chat, if you can see it.
Talana is also one. What did Talana say in the chat? I'm not able to.
Hold on a minute.
Caregiver, and so did you want me to read it? Patricia, you're going to go ahead and take that.
Pardon me?
I can summarize it. So she indicates that while the impacts of Zoom are a bit exhausting, it's definitely a way, an opportunity for participation when people aren't feeling well or if they're hospitalized, and that it has increased the monthly support groups interactions that they sponsor.
Yes, like I want to share like, just a brief story because I know we're on time and we love you guys' questions and things like that. But during the planning, organizing of the summit, a few of us became ill and our planning and it was unexpected because usually for myself, the summer months don't bring challenges for me. I mean, you know, it just depends. But I had a challenge right maybe was it a week or two ago that, and then I think I can't speak for Maxine, but we've all had during the planning of organizing the summit, coming together, we've all had a few challenges with, but Zoom has allowed us to stay connected, allowed us to continue our meetings. Even if we wasn't feeling well, we still kind of got on to participate. So that's how that Dr. Sue helps answer your.
Any more
Are there
I would, I'm
questions?
sorry, I would like to say a little bit of something. Just to let you all know that I am Maxine Banks and I'm 55 and I do live with SC disease. And I usually generally don't have challenges, but recently I did have one. And it's good to have the Zoom platform because I'm in Peoria, so they're up north. It is good to have the Zoom platform. It's good to have the support group. That way you'll have someone who can identify with what you're going through. Yes. And it is good to see faces and talk to all the ladies and share our stories. So I would like for us one day, whenever, if this pandemic ever end, I would like for us all one day to meet. And I would love to drive up north. It's just me. I would like for us to all one day sit in a room where we can talk and hug and share and cry if we need to. But Zoom helps. Zoom helps. I'm just a people person and I like the touch. But Zoom is a big help.
Yes. And I just want to say something too on behalf of CAB. I know we've all shared leadership roles and things with CAB, and we just want to take a little moment to say thank you to ISAT, the ISAT team. I know we're part of the CAB is a part of the team, the advisors are part of the team, and we just want to say thank you guys for welcoming us and allowing us the platform to be able to take a little bit of leadership role with the summit. And you are inviting us to hear our ideas, our thoughts, our concerns, our stories, everything to help ISAC be productive and do a wonderful job. Collaboration this year was excellent and it's moving forward. So we just say thank you guys, Dr. Gordu, Dr. Sue, the entire ISAC team from the CAB. We appreciate you guys and just say thank you for the group.
Are there any more questions or comments?
Yes, thank you, Dr. Sue, for. I'd like to kind of reiterate what Dorinda said too. This is a great team to work with, and you learn so much, and you do have the autonomy that I spoke of, and you get and yes, in the Zoom platform we have our teleconferences by phone. Well, actually WebEx, but you don't always have to show your face, and so communicating remotely for some is a bane, and for others it is a balm. So I have no problems with Zoom.
Yeah, same here. None. Any more questions? Do we have any more?
I would like to add, we would like some male volunteers as well from the sickle cell community, caregivers, or persons living with the disease.
And that's our other CAB member that's talking, Beverly. She's okay.
All right, anything else for the advisors? We have a couple of minutes, but if not, we can move on.
And we're not going to leave Talana out. Tell Talana she's welcome to meet the camera. We all decided to meet together. And Talana, you're welcome to join us, of course.
This is Dr. Corduke. I'd like to once again thank the advisors for your participation. It's been really wonderful, and I think it's in a way groundbreaking to have such insightful, important, intelligent input into our program. I'd really like to see it continue to expand and become an essential part of sickle cell care nationwide. But thank you so much, and I'm glad that we see Maxine here because she has been a part of the process. So we really glad to see you here as well. So thanks again to all of you.
Monisha, you're welcome to.
All right.
Thank you.
So now, okay, thank you so much. So now the principal investigators at Isaac's collaborating sites, the University of Illinois Hospital, Sinai Chicago, Lawndale Christian Health Center, and the University of Illinois College of Medicine in Peoria are going to share some of their updates.
Thank you. You're going to show the slides, correct?
Beverly
Yes,
is.
I will share the slides.
Dr. Gaddu, please start.
Okay, well, thank you. We wanted to just give a brief overview of the types of, bird's eye view, the types of programs and services we offer at our different sites. So if you could put up the, yeah, thank you. Do we have the next slide, please? This is for the University of Illinois. The goals and vision of our Sickle Cell Center are to provide compassionate care and state-of-the-art treatment for sickle cell disease. We also seek to be a leader in research to find new treatments for sickle cell disease and to understand its complications so that we can find new ways to prevent them. An overview of our program is that we have a lifespan approach. We have a very important pediatric program and a very vigorous adult program. We try to give comprehensive care that focuses on relieving pain and preventing complications. We have pediatric and adult sickle cell disease outpatient clinics that you're really welcome to contact to have an appointment. Sometimes people come to us for second opinions about their care. Sometimes they transfer their care here if they desire to have the breadth of expertise that we have. We have an emergency department that provides really excellent care, and you met Dr. Kola as part of this conference. We have an acute care center where patients who have an uncomplicated pain crisis can present for efficient, rapid control of their pain using an individualized pain plan. We have dedicated pediatric and adult inpatient care. Very importantly, we have a team of 4 doctors, specialists in sickle cell disease, who provide care for our sickle cell disease patients in our inpatient unit. And I think we're really unique in that regard of having such a large, dedicated, highly specialized team of inpatient care providers. And we have an interprofessional team that includes a clinical pharmacist. Next slide, please. Taking a closer look at our center, we have an innovative stem cell transplant program led by Dr. Rondelli and Dr. Saroff that has cured more than 50 patients in the past number of years. This is an ongoing program, and especially people who have siblings from the same father and mother are candidates for this approach and can contact us for evaluation. We provide rapid, effective management of uncomplicated pain crises in our acute care center. We have an adolescent to adult transition program that Dr. Sue is in charge of. We have experts in many areas: blood transfusion, cardiology, nephrology, neurology, ophthalmology, pulmonary medicine, orthopedics, and wound healing. We also have a vigorous molecular and genetic translational research program. And we like to promote community sickle cell awareness and advocacy. Also, we would like to have new approaches to patient education, care coordination, and including sickle cell disease patients in program leadership. And I think you've seen that this morning. And we're involved in training many healthcare professionals, and we're active in global health education. And so we're really, really delighted for the patient leaders that are a part of this Sickle Cell Summit and have organized this summit. So thank you so much again to Beverly, Bridget, Dory, Dorinda, and Maxine. And one other thing I'd like to say is that the Isaac program has been managed very effectively and expertly by Judy Mopsa. Not hearing too much from her, but she's a very, very towering figure in our program. So thank you again. I'll turn it over to the next speaker.
Thank you, Dr. Gerdug. Our next speakers are from Sinai, Chicago. Dr. Larissa Verda will go first, and then Dr. Ananta Pandit. Dr. Verda?
Yes. Hi. Can you hear me?
Yes.
Yes. Next slide, please. I wanted to say thank you very much, our whole Sinai team, Patricia, Dr. Pandit, Dr. Sebro initiated that, and Dr. Vishal Quatra, who is now a resident in our residency program. So thank you. We started with the small participation with Isaac. Our numbers are not as huge, and we are not a big academic center. We are just 1 mile away from you guys at UI Health, and we just want to bring that sickle cell care close to the community. So we have kind of two, thanks to support and collaboration with Isaac and University of Illinois, we were able to kind of establish sickle cell clinics. In North Campus is our Mount Sinai residency-based clinic under my supervision, where at least 3-4 residents are rotating on everyday basis, and Dr. Pandit's clinic on South Campus on Ashland Avenue. We have hematology oncology clinic in North Campus as well, and for complicated patients, we can always refer them or arrange to be seen in hematology oncology. We focus, can you share next slide? Thank you. So these are our kind of coordinates. So what we are trying to do, we are primary care physicians, we are internists, but thanks this collaboration, our knowledge of sickle cell disease, as well as needs of sickle cell disease patients for special care to prevent complications is being raised, and we are proud now that we can provide hydroxyurea management and pain management with possibility as well to refer to pain specialists. We do not have a individualized pain plan, but what we did, we created documents we shared with our patients, providing our contact information so they could present it when they go to emergency room. And with our high-risk pregnancy clinics, labor and delivery, neonatal care, we were able to provide as well care for pregnant women and with sickle cell disease. Next one. And Dr. Pandit can say for himself, this is Dr. Pandit in front of his clinic on Ashland Avenue. And I just wanted to finish with a little quote from my resident. So patients are not problems to solve, but people to care for. And that's what we are about here in Sinai for compassionate care. Thank you.
Thank you, Dr. Verda. Dr. Pandit.
Okay, good afternoon, everyone. Thank you, Dr. Verda. I am Ananta Pandit. I'm one of the primary care physician affiliated with Sinai Health System, and I do both I do a traditional practice with both outpatient and inpatient services. And my outpatient service location is at Englewood Community in the south side of Chicago. And I've been doing this for more than 10 years. And I provide inpatient services at Holy Cross. I became part of IJAC team since 2018. As Dr. Kola mentioned earlier about the barriers between sickle cell patient and seeking emergency care, I have made my commitment to minimize that barrier. For that, at my office, I provide prompt appointment for sickle cell patients. They can walk in if needed, and they also have a direct access to provider if needed. Next slide, please. For health maintenance, I make sure they are up to date with the immunization, like getting pneumococcal vaccine, flu vaccine, COVID vaccines, and other appropriate vaccinations, reassuring compliance with the treatment plan, including pain management, use of hydroxyurea, Indarvi, folic acids, etc. My goal is also to educate patients about self-treatment at home in case of impending crisis, like taking a bed rest, taking analgesia, maintaining hydration. And if all those measures fails, then they can go to emergency department. I also make sure that I check the renal function, blood pressure, and periodic eye exam, and also teach them how to recognize the signs of early infections, if they are having increasing anemia. And depending on their symptom presentation, I make sure that I do screening for pulmonary hypertension, if they have any sleep disorders, kidney disease, renal pulmonary function testing, if there's a signs and symptoms of a vascular necrosis of femoral and humeral head, then getting tested appropriately. And also if they are having gallstones, so all the preventive tests as appropriate. Next slide, please. So overall, my goal is to minimize that barrier between sickle cell patients and getting emergency care, and improving overall health condition of patients with sickle cell disease, including educate and appropriate pain management, preventing their frequent ER visits, improving patient compliance with the treatment plan, follow-up, and overall improve quality of life. Thank you.
Thank you, Dr. Pandit. Dr. Sanders from Lawndale Christian Health Center.
Okay, good afternoon, everyone. Next slide. I'm a pediatrician over at Lawndale Christian Health Center. We're located on the west side, and we serve both the North and South Lawndale community. And this slide just has a map of some of the different locations that we have. We have a clinic in Farragut Academy. We have a clinic at Holman Community Health Center, and we also have a clinic on Archer, and we have an eye clinic and dental, as well as fitness center and immediate care. Next slide. We have over 40 clinicians that provide care for both our pediatric and adolescent patients who have sickle cell disease. We do basic preventive medicine for them. We have care coordinators and care managers that provide support in facilitating care, including specialty care. We have transition of care teams that help to connect patients back once they've been admitted to the hospital or seen in the emergency room to have a follow-up appointment with their primary doctor. We also have access to integrated primary care behavioral health science services, which we have on-site psychologists as well as telemedicine. We have 2 adult psychiatrists on our staff, as well as 1 consultative ped psychiatrist from Rush. And we also have connection with our social support groups at local hospitals. We provide both pediatric and adult medicine at our Ogden campus, our Breakthrough campus, Holman, Farragut, and Archer. Again, immediate care. And we do have curbside lab services and also COVID testing and vaccinations. We have on-site pharmacy, X-ray, and also substance use disorder treatment and recovery groups. And again, referrals to specialists through surrounding hospitals, like we've been talking about, Sinai, U of I, and Northwestern and Rush. We also provide social support for nutrition services through our on-site dietitian who's available for certain hours and days. We also have a veggie prescription program through our farm on Ogden, which allows our patients to be referred free of charge to access affordable fruits and vegetables, as well as the farm on Ogden is open throughout the day just for general purchase of fruits and vegetables. And we also have our fitness center, which is open 6 days a week, as well as it is a safe place for wellness and physical health. Next slide. These are our general demographics of our clinic. We overall care to over 16,000 pediatric patients based on data from 2020. Over 14,000 had Medicaid, which is majority, 88%. 1,010 were uninsured, and the rest, 987, had private insurance. 53% of our patients identify as Hispanic or Latino, and 39% identify as Black or African American. We have, based on our data from last year, 43 active pediatric patients and 72 active adult patients. And we've been a member of ISEC since 2018 with Dr. Rowe initially, who's one of our clinical quality directors, started, and then I joined him as well. And we strive to have a patient-centered approach in what we do to show and share our love for people and our love for God. Next slide. And this is just pictures of our fitness center and our Green Tomato Cafe, which is also located in there. We have some healthy nutritional foods for sale, as well as a veggie prescription. I'm sorry, the Farm Oregon and the veggie prescription program, which is the lower left side, has that shines in the evening. And then we also can refer our patients for 6 months of free membership to the fitness center if you have any type of chronic disease or any based on your provider's need that you may be to refer, you can come to the fitness center. And the price is fairly low at $10 or $15 a month. And that's it. Thank you guys for letting us be a part to serve our patients on the West Side. Thank you.
Thank you so much, Dr. Sanders. Next, we have Dr. Kay Sabing, who's at the University of Illinois College of Medicine in Peoria.
Good afternoon. Next slide. I want to thank you for this opportunity to tell you about our sickle cell program and to orient you, since most of you are in Chicago, to orient you outside of Chicago. The top of the slide pictures the beautiful downtown Peoria skyline reflected in the Illinois River. Our Peoria program is a joint effort of 2 local institutions, OSF Healthcare St. Francis and its Children's Hospital, and the University of Illinois College of Medicine branch in Peoria, with a third partner being St. Jude Children's Research Hospital in Memphis, since we are a St. Jude affiliate. We are an academic institution and a tertiary referral center with many adult and pediatric subspecialists available to care for our patients. Our 125 patient pediatric clinic children live mainly in the part of the Illinois map that's outlined in red, with Peoria near the center. Our outreach clinic sites are named in the white rectangles. On the left are the members of our sickle cell care team. We offer many specialized services, including individualized pain plans, transition to adult care, and clinical trials. Next slide. Our new adult sickle cell primary care clinic is staffed by a medicine pediatric physician with hematology support from myself, a pediatric adult hematologist, a Peoria adult hematologist, and Dr. Faruqi at UIC. We also have an adult emergency department champion with both local physicians pictured here on either side of our clinic logo. And as you can see, we just started this clinic in February. Our adult support group is attended by our own community health worker and a local part-time community health worker from the Sickle Cell Disease Association of Illinois. Being a part of ISAC and SCDIC has been very helpful to us in exploring new ways to locate patients to join our new adult clinic. and how to better incorporate individualized pain plans and improve care overall in our emergency department. Next slide. The upper left portion of this slide shows members of our team and our annual September Sickle Cell Celebration event with food, games, and educational events. The lower left gives information on our back to school event at the Peoria Playhouse Children's Museum, where each child gets a backpack when they come to this August event. The rest of the slide depicts the front of City Hall with team members and an adult sickle cell disease warrior who last year accepted the mayoral proclamation of June 19th as World Sickle Cell Day, with the lighting of one of the Peoria bridges pictured in red for the occasion. Last slide. The next slide. Here are the hospital and university campuses, proving that we're not really sitting in the middle of a big cornfield, which many people think we are in Peoria. Our contact information for those involved in our clinic is on the left. And in closing, besides thanking everyone involved with Isaac, I want to acknowledge Linda Drawhorn and Beverly for being wonderful Chicago-based nurse and warrior advisors for our team for a number of years, as well as all of our sickle cell warriors and families who we are very privileged to serve. Thanks.
Thank you, Dr. Saving. I didn't know Peoria was so beautiful.
It's very nice. It's very nice.
Mm-hmm. Are there any questions for any of the partner sites? Any of the PIs at any of the sites? I see Bobby Lee Arnold has her hand up.
Yes, on the site, the Christian Center. I can't remember what the what
Longdale Christian Health Center.
Yeah, I was wondering, you have 2 psychiatrists on staff, and even though I'm a patient at the UIC, am I allowed to use that psychiatrist? I mean, will I be welcome? Because I've been looking for a psychiatrist for about 1.5 years, and I can't find anybody who accept me as a patient.
Mm-hmm. Well, we have the behavioral health model where we hand off, the patient usually sees the primary doctor and then they're hand off the same day. So you may already have established care, but we do see new patients specifically for behavioral health, and it would be a handoff to see the behavioral health for that particular set of visits. It's not, they don't do like ongoing counseling, but they can do it for sometimes up to maybe 6 visits or so. And then from there, try to help you to find other resources. So it's kind of there for that acute time or a period of time. And they also can help you to further get some other resources.
So, I mean, well, I have a GP at UIC. So I would have to write an order or something. How would I go about that, please?
Not necessarily referral. You just would have to be start out as a new patient at Lawndale, not necessarily establishing your care there. You don't have to necessarily transfer, but you still would be a part of the Lawndale family and a part of the clinic as far as having a chart there and information, but you still could see your regular doctor. But we also would have you have a doctor at Lawndale as well to be able to be handed off to one of the behavioral health psychologists.
So go to the ER is what you're saying? I mean, where do I go? Just call the
clinic? You can just call the clinic. Our number, I can put that in the chat for you.
All right, thank you.
Mm-hmm. You're welcome.
Dorinda, did you have your hand up?
Yes, this is, I just wanted to say, same thing with Dr. Sanders. That's really, really good information to know. They have the fitness center for the patient. These things are really great to know. I'm glad you guys have shared so much information with people with individuals. I didn't even know, but that sounds really in the veggie program and all those things are really exciting, and it's really good information. Thank you for sharing.
So Maxine has asked, what is the veggie prescription program?
Okay, sorry. The veggie prescription program is a partnership that Lawndale has with the Chicago Botanical Gardens, where what you do is when you come in for your doctor visit, we give you a referral, we put you in the schedule. They have times from 11 to 2 on Wednesdays, and then 12 to 3 on Thursdays rather, where you come and you can, during the pandemic, you can just drive by and pick up a box of vegetables, fresh vegetables. And you do the boxes for I think 6 times. And they also can provide you before the pandemic instruction on how to prepare healthy, how to cook those particular vegetables, but they probably more so are doing more just like a handout about how to make recipes for healthy, how to use those vegetables. And also we have Truly Gannon, she's a nutritionist, so she's usually there at the times of those particular appointments. So you just basically would get the referral from the provider, you would go pick up your vegetables, and then if you have a question or concern about how to, eat healthier, you can talk to nutritionists as well at that particular time that you pick up your vegetables.
Thank you. Are there any additional questions or comments for the panel of our partner sites?
This is Dr. Gordick. I'd just like to say how wonderful it is to see all the activity going on at the community level for sickle cell disease and progress being made in the area. I'd like to give a lot of credit to all of you. Thank you so much.
Yes, all the facilities, yes. Oh, yes.
All right, we are going to take a very short 2-minute break, and then we will start our 3rd session. Thank you, everyone.
Can you hear me? Okay. Well, I'd like to. Oh my God. I'd like to move us along to part of our the 3rd session.
Bridget, are you on twice? You'll have to mute one of them.
Right, I'm trying to mute. A minute. Fine. Can you hear me now? Okay, I'd like to move us along to the 3rd session, which will focus on community collaborations, connections to specialized care and services, where we will hear from other healthcare systems. Rush, University of Chicago, Comer, and Northwestern. Dr. Lacey, I'll give it back to you.
Our first speaker of this session is Dr. Kenneth Cohen, who's an associate professor of medicine at the University of Chicago Medical Center. Dr. Cohen, can you start?
Sure. Thank you so much for letting me join today and inviting us. Do you want me to share my screen and share my slides?
Yes, please. Thank you.
Sounds good. Let me go ahead and do so. Can everyone see my first slide, my introduction slide?
Yes.
Fantastic. So again, thank you so much for giving us the opportunity to join the summit today. I just want to say it's been great to hear about the number of community-based programs and the services that they can provide. And I'm going to be completely honest, I've got some ideas now for things that we can do and incorporate into our group and our center here. Just very briefly, since this is a talk I'm giving, I have no conflict of interest or financial disclosures, and I serve on what's called an ABM task force, which is a board certification task force, and this has nothing to do with that. So just have to officially state those. I wanted to give a sort of a big picture view of our group here and our program here. Our program is very clinic focused. The hematology clinic is where our sickle cell disease program is centered. It's its home, it's our clinical home. But it's important to know that our clinical home in the clinic, and that's where I am right now, collaborates with a number of other groups within our hospital system. Importantly, the emergency department, the inpatient hospital teams up here, something called the CTC Day Clinic, the Care Transitions Clinic Day Clinic, which is our infusion urgent care center for patients with sickle cell disease and other diseases, and of course the blood bank too. And so even though I have this slide showing these sort of bi-directional arrows between us and these other groups, actually all these other groups collaborate as well. And so it's common for the emergency department to collaborate with the day clinic and vice versa, and the day clinic to collaborate with hospital medicine, and for all of us, of course, to collaborate with the blood bank, critically important groups. I wanted to briefly talk about our clinic. Our team consists of 4 people, 2 physicians, nurse practitioner, and a collaborative nurse. Over on the right, you can see some of our pictures with Pat Chapman-Kelly, our nurse practitioner, and myself and Chris Doherty. Unfortunately, I don't have a picture of Deja. Our clinic focuses on the longitudinal management of patients with sickle cell disease. As other groups have noted, it's important to think about chronic symptoms and things to watch out for, and to provide education for patients. It's also important to think about disease-modifying therapies as well. And here we focus on the use of hydroxyurea, encouraging for most patients, but also having access to other disease-modifying treatments such as L-glutamine, crizanlizumab through our IV therapy center, voxelotor, and scheduling regular and routine blood cell exchanges, red blood cell exchanges. We don't have an established program in transplant. So for our patients interested in transplantation strategies, we'll oftentimes collaborate with UIC. Our clinic is also where we create individualized pain plans, and also where we collaborate with community health workers. We have a community health worker program that just started in the past year to really help guide and improve the care of patients in the community. We also have the Care Transitions Clinic, which I want to spend just a few minutes on. This is a care unit that's designed for the urgent care of patients, not just for patients with sickle cell, but also for cancer patients, patients with chronic bronchitis, et cetera. But we are excited about the fact that our sickle cell patients can be treated here. They can provide an alternative option from the emergency room. So I think, as everyone knows, emergency departments can be quite busy, and people oftentimes can wait a long time before getting treated for pain. This provides a much faster way for getting patients pain control as quickly as possible. It's not just for our own established heme clinic patients, but it's also available for patients who are out of network as well. Again, it provides urgent care and treatment of patients with uncomplicated pain episodes. And so if someone's having a more complicated issue, acute chest syndrome, for example, they are better served in the emergency department. We don't have a lot of appointments available per day, but we have a sufficient number, and we hope to expand. And again, patients can receive oral, IM, or intravenous pain management, hydration, and transfusions, and oxygen. Patients can be discharged from the unit or admitted to the hospital. This is just to give you pictures of who's behind the CTC. It's run by Dr. Valerie Press. And what you see here are numerous people involved either in the management of the clinic or direct patient care. We're also excited about the introduction of a dedicated inpatient sickle cell consult team. So for patients who get admitted to the hospital, they're cared for by general medicine teams. And when general medicine teams need assistance, they traditionally consult the inpatient hematology team. This team, of course, can help manage patients with sickle cell disease. They also manage patients with other hematologic disorders. We're developing a dedicated sickle cell consult team, which is strictly for patients with sickle cell. It's going to go live on July 18th. It's being run by Dr. Nabil Abu Bakr and a team of advanced practice providers, some of whom have experience in the care transitions unit, actually. And the goal is to, again, speed pain control, get people's pain under control as fast as possible, really make sure there's consistent use of individualized pain plans, consistent tapering strategies, and also really improve that inpatient to outpatient care transition. We're also thinking about how to use it to implement new strategies. So I mentioned that we do like to start hydroxyurea for patients as an outpatient. We have some patients who are admitted to the hospital and can't make it to the clinic for initiation of hydroxyurea, who might still benefit. And so we're implementing a new strategy to begin hydroxyurea as an inpatient. And again, just as the clinic works with community healthcare workers, the inpatient teams can work with community healthcare workers for post-discharge coordination of care. And this brings me to my last two slides, which is how do we bring this all together to improve the care of patients? We have a number of different groups here taking care of patients in the clinic, where I am right now, in the emergency department, urgent care, CTC, inpatient, and even in the blood bank as an outpatient, outpatient exchanges. And so we've identified a number of areas to focus on. Most of what I've talked about has to do with how do we improve pain management, get pain under control as fast as possible. Part of this involves physician education, both here in the clinic, also in the emergency room department, but importantly in the hospital. We feel that implicit bias training is critically important to work on improving healthcare disparities. Access to care is incredibly important. We're trying to improve our case management, social workers, and provide psychiatric assistance as well. We're also focusing very heavily on improving the use of hydroxyurea for our patients. And in the second to last slide, I have just a slide that talks a little bit about the time course of how we've been reorganizing ourselves. So lots of abbreviations here. I don't want people to focus too much on those, but I do want to mention, that we actually created a sickle cell disease working group back in 2018. So it's about 4 years old, really to think about all aspects of sickle cell care here. Then in 2019, we began some educational type endeavors. By 2020, we were really focusing a lot on hydroxyurea. By 2021 is when we opened that care transitions clinic, that care transitions unit, which has had a major impact on improving, again, urgent pain control and helping people avoid the emergency room. And again, for 2022, we're quite excited about our inpatient dedicated consult team, and again, working with other programs as well. So my final slide is more of a thank you slide to our team approach. Again, we introduced some members of our outpatient hematology care team, but what we have here is basically a number of people you can see from quality improvement, from emergency room, from the sickle cell day clinic, from the hospice teams, even some of our trainees who have been involved in research to improve the care of patients with hydroxyurea. So again, big group of people all working together, trying to move the care of patients with sickle cell disease forward. And with that, I think that's my last slide, and I can now stop sharing.
Thank you, Dr. Cohen. We'll address all the questions for the affiliates at the end of the group session. Thank you. Okay, so next, I believe we're going to go with Dr. Radhika Panditi, also from the University of Chicago Medical Center. Dr. Panditi?
Yes, I'm here. Sorry, I had my, I can share my slides. All right. So hi, I'm Radhika Pedinti. I am a pediatric hematologist oncologist at the University of Chicago. And at the University of Chicago, our pediatric sickle cell care is divided between Laura Beta Children's Hospital, which is over here, just for, I put a map in there just so folks know where things are. Laura Beta is here. It's on the lake. It's a chronic disease hospital. We have some inpatient care, but most of the care tends to be, outpatient. So our sickle cell outpatient clinic is set at Laura Beta Children's Hospital, and Comer Children's is about 3 miles away from Laura Beta, where most of our, inpatient care and radiology services, etc. are. At Laura Beta, we follow a comprehensive care model for patients with sickle cell disease. So they have, and we are the medical home. So for most of our patients, about 70 to 80% of our pediatric patients that we follow at Laura Beta, we are also the primary care provider. So between me and a nurse practitioner in my clinic, we tend to be the pediatric the PCPs for our patients with sickle cell disease as well. We do have a small acute care clinic that is at Laura Beta Children, so that if, folks come in with, fevers, basic pain management, we can take care of that at Laura Beta. Anything that, if patients have respiratory issues and such, and even if they end up coming to clinic, we send them to, Comer for higher level of care. We follow a total of about 460 patients with sickle cell disease between Laura Beta and at Comer. Children that, we follow children, like I said before, at Laura Beta. So from birth, we come to us through the IDPH newborn screening program till 18 years of age or high school graduation, whichever comes first, we follow them at Lara. We have 3.5 days a week of clinic at Laura Beta. We have a specialty hydroxyurea clinic, which is on Friday afternoons. And then we have a combined sickle and pulmonology clinic as well for our patients who have either concomitant asthma or patients who've had, multiple acute chest syndromes, etc. We can follow them along with our pulmonologist, and she tends to, again, all of us, we work the same way. So I have outpatient clinic at Laura Beta, but I'm a faculty at the University of Chicago, so we see them, inpatient over here as well. And it's the same with our, with our pulmonologist as well. So she knows them from their admissions at the university, and then we follow them together at the at Lara. We also have an adolescent young adult clinic. So as you can see, we are, physically located in 2 different spaces. So, after they turn 18, 19 years of age, when we are ready to, talk about transition, it was very difficult to ensure that they end up going to, the adult side as we anticipated that they would, because there was a, just even the sheer, location differences and how to navigate that space was very difficult. So we started the clinic about 5 or 6 years ago. It's housed at Comer Children's Hospital. It's actually housed in our Peds Heme Onc clinic space. We have one afternoon a clinic. Patients are seen other days of the week as well. As Dr. Ken Cohen had alluded to in terms of infusion centers, that is a part of the emergency room. Our infusion center is a part of our pediatric AYA clinic space. So even though we have clinic only 1 day a week, there are other days of the week that we see these patients for either outpatient pain management, if there are transfusion needs, if they need other infusions like crizanlizumab, etc. They are seen on other days of the week as well, and they are seen in our infusion center / day treatment room, which is where patients are getting, chemotherapy and all sorts of other things. And there are rooms that are, earmarked for sickle cell as well. So in this clinic, we see patients 18 to 25 years of age. We actually end up admitting, if patients need admission, we even admit patients up to 22 at the pediatric hospital, and only after that do they start getting admitted to the adult side. But I still continue to follow them as an outpatient. So basically, it's a very phased sort of transition. First, they change location, but not physician, and then they change the space where they're getting admitted, but they're still followed outpatient with us. And between 24 and 25, we transition them over to the outpatient care on the adult side as well. Along with it, on Monday afternoons, we also have, our stem cell transplant team is also a part of our Monday clinic. So if there are consultations that are needed with the stem cell transplant team, they happen, at the same time. So this is our sort of Sickle cure clinic. So even patients that I see over on at La Rabida and our AYA patients can, meet with our transplant team at the same time. So this is our, physician. Unfortunately, I haven't put pictures of all of us here, but like I said before, we are about 400 plus patients. It's 2 physicians, so it's me and Dr. Wendy Darlington, who are a part of the sickle cell team. Tanisha Jones is my nurse practitioner who is at La Rabida, and Casey is our nurse practitioner with our AYA program. We have 1 nurse coordinator who works mostly at La Rabida, helping us with, scheduling our, initial triaging, and also with, some of the, as you can imagine, the bridge that's needed between Comer and La Rabida. We have a family advocate that's a part of our clinic as well, and a social worker who's a shared resource with for the adolescent young adult clinic. I've put the numbers over here for when we have clinics and such. Like I said, we are in clinic. We have 3.5 clinics at La Rabida and another half day of clinic at Comer for AYA. We are also a part of, at Edward Hospital in Naperville. We have a clinic there too, Wednesday afternoons. And those are for patients that are out there in the western suburbs. But if they need, again, and Edward Hospital, you can even, admit patients. They're able to get their, transcranial Dopplers and such over there as well. In terms of pain management, again, like I alluded to before, we do have an infusion center or day treatment room, which is a part of our general heme clinic where patients can come in for pain management. And again, we can accommodate about 2 to 3 patients a day. Certain days we can accommodate more. All of our patients have standardized pain templates that are followed in the PEDS-ER. Our adolescent young adult patients have IPPs, individualized pain plans, both for emergency room and for inpatient as well. Our palliative care team provides some of our chronic pain management as needed. They can see them as an outpatient, and they can also be, they also see them inpatient because we are able to do ketamine infusions on the floor. We have a psychologist that's a part of our adolescent young adult clinic. And so she sees them mostly outpatient and serves as a bridge should people need more in terms of, accessing psychiatry or other psychology services. And again, we do have the adolescent transition program, as I talked about earlier. Our sickle cell, stroke screening, like transcranial Dopplers, all happen at Comer. And we have a psychologist who does neurocognitive testing. She is very much a shared resource with everything else. So I can't say that we are able to get a lot of neuropsychology testing done, but certainly, we do have, access to her as needed. And then we are able to refer some patients over at Comer as well. We do not have a parent support group. We do have multiple pharmaceutical trials and the Novartis gene therapy trial that's available. We have an institutional haploidentical transplant trial along with a reduced intensity trial through the STAR consortium. And then here's some of our pictures, but this is this picture, the first one that you see near the water, that's La Rabida Children's Hospital, and that's our outpatient waiting area. This is Comer Children's Hospital, and these are pictures from some Skadai walks from the previous year. And this one is our, we have a sickle cell patient registry where we have about 350 patients who are a part of the registry. And really that helps to, since we have 2 medical record systems at 2 different hospitals, this helps bring together all of their information into this registry to be a sort of searchable database. And then we have some biobanking studies, we have a quality of life survey and some QI projects as well. So that's my last slide. And I'm happy to take questions whenever you're ready.
Thank you, Dr. Panditi. We'll do questions after the speakers, the next 2 speakers finish their presentation. And so with that, our next speaker is Dr. Shivi Jain, who is from Rush University Medical Center.
Thank you, everyone. Can you all hear me?
We can hear you.
I'm going to share my slides.
Okay.
So I would like to start by thanking everybody for this wonderful presentation. I have really learned a lot in the last few hours. So I am the director of the Adult Sickle Cell Program at Rush University Medical Center. So Rush has contributed significantly to the health and serving patients in Chicago for almost 200 years now. Sickle cell disease was first described at the St. Luke's Presbyterian Hospital in 1910, which is now the Rush University Medical Center, by Dr. James Herrick in a patient, Walter Clement Noel, who was a visiting dental student from Grenada and used to get admitted for pain and anemia. And this is actually a snapshot of the first report of his blood findings and the symptoms and the first correlation. So I'm proud about that historical connection. So at Rush, our mission is to provide, improve the health of individuals in diverse communities that we serve through integrating outstanding patient care, education, research, and community partnerships. Our values lie in the I care, which is innovation, collaboration, accountability, respect, and excellence. And that is our roadmap to our mission and our vision. So I wanted to share the fiscal year 2022 landscape of sickle cell disease in Illinois. And this map tells us where most of the patients are located in the state of Illinois. And you can see the highest population of patients is in the Cook County, where we are located. This is the contribution and collaboration between different institutions who are currently serving sickle cell patients across the state of Illinois. And we are represented in the green over here. This is showing the age distribution of the patients with sickle cell disease in Illinois. And I wanted to point out at this very interesting shift from sickle cell disease now no longer being a pediatric illness, but most of our patients are now young adults and mostly in the age group of 20 to 45 years of age. And that emphasizes the need of more adult sickle cell programs in the state and across the country, and stronger collaboration between pediatric and adult programs like we see for some of the other chronic disease states. So our sickle cell program's mission is to deliver quality team-based patient-centered care that is economically sustainable. We all are familiar with Dr. Cantor's article and the different models of sickle cell centers. Ours is the embedded care model because we are embedded in our cancer center. Hence, we share resources when it comes to staffing, infusion area, urgent care services, and clinic space. From the same article referring to the core elements of a sickle cell center, we have some of the essential and optimal elements. We are a very new program. We only started in June of 2020. So we are still building and growing. So our team has hematologists. I have a nurse navigator, and we're actively looking for a nurse practitioner for our program. We strongly collaborate with our palliative care pain management colleagues. Dr. Kaur and Dr. O'Mahony head that part of the program. We also have collaborations with hospital medicine, and our sickle cell champions are Dr. Bruti and Dr. Goetz from the hospital medicine team, and Dr. Martin from the emergency medicine team is our sickle cell disease champion. Terry O'Brien is our nurse practitioner lead in urgent care, which is like our acute care center where we provide care to our sickle cell patients in the day hospital setting. We have a strong team of nurses and infusion in the infusion space, apheresis area, and also pharmacy that are supporting our program. We are trying to identify sickle cell champions in other subspecialties like nephrology, cardiology, orthopedics. And we also have support from care management team, EPIC. We are building OrderCest to streamline the care for sickle cell patients, and marketing team to be able to understand what are the patients that we can serve better in the state of Illinois. I'm very proud to share that I have Dr. Yarboy, our clinical psychologist, who sees patients in our comprehensive sickle cell clinic once a month, and our patients have really appreciated that support. And Nia Butler, who's our social worker, has been on our team for the last 6 months, and has been a very, very valuable resource for the patients. This is our space, our cancer center in the professional building on the 10th floor. This is a check-in area for our infusion clinic. This is one of our infusion rooms, our clinic exam rooms, and the happy nurse practitioners in the urgent care who always are welcoming patients and happy to see them. As I said, we are a very young program. We only started in June 2020, so there is lots of room to grow. And as I said, I have learned a lot from this summit today. So we need to develop a transition program from pediatric to adult. We also need to have a stronger program to support our pregnant patients with sickle cell disease. We are developing individualized care plans. We have about 8 of them right now, and we are working on implementation of those plans for our patients. With Dr. Martin, we are trying to develop fast track for sickle cell patients in the ED so that patients don't have to wait hours. We work very closely with Sickle Cell Disease Association of Illinois, and I really want to acknowledge and appreciate their efforts in the community for the sickle cell patients, for their advocacy and support. And we eventually want to expand our multidisciplinary outpatient care and mental health services. We do face challenges right now, like high readmission rates for the patients, and I'm hoping with the implementation of standardized protocols and individualized care plans, we will be able to achieve those goals. And with the expansion opportunity with the new space, we are hoping to expand and streamline care for sickle cell patients. Before I end, I want to acknowledge and remember Shonda King, who was a pioneer and a great social worker and colleague that I had the opportunity to work with at UI Health. And her demise has been a big loss to the sickle cell community. I really enjoyed my time when we shared the same space in the clinic time. And I also learned a lot about patient perspective on sickle cell disease from Shonda. So with that, I would like to end my presentation. I would like to thank the organizers of this 5th annual summit for inviting me. I want to thank my team of adult sickle cell program at Rush University and my leadership who supports my vision. I want to thank Sickle Cell Disease Association of Illinois and Talana Hughes for her unceasing support for my program. But most of all, I want to thank the patients for their trust in me to be able to care for them and serve them for the sickle cell disease. Thank you, everyone.
Thank you so much, Dr. Jane. So our next and final speaker of the panel is Dr. Robert Liam from Northwestern Medicine.
Hi, good afternoon. I'm going to just share my screen. Okay, great. Thank you so much for this opportunity to talk a little bit about our sickle cell program at Lurie Children's. My name is Robert Leam. I'm the director of the comprehensive sickle cell program, but I'm also the interim division head for the Center for Cancer and Blood Disorders. As some of you may or may not know, Lurie Children's Hospital represents the Department of Pediatrics for Northwestern Medicine and the Feinberg School of Medicine. I've just broken up the slide into our clinical and our research mission. We serve about 400 to 425 children and young adults and their families affected by sickle cell disease. All of our clinics are what we consider multidisciplinary. So we have these clinics where we embed not only our providers, but also nursing, genetic counselors, our social workers. We have a pediatric dental resident, and most recently, we've incorporated ophthalmologists who come to our clinic to see our patients directly in clinic. Besides our multidisciplinary clinics, we also have a number of special clinics We have clinics specifically targeted at children and patients who are on hydroxyurea. We have what we call a TOTS clinic, which is a really great clinic for children under 5 years of age, where we embrace this concept of the medical sickle cell medical home and really focus a lot on education. And then most recently, because one of our providers is also transfusion medicine trained, we have a clinic that's dedicated to patients who are on chronic transfusions. A number of our patients are on chronic transfusions for many different indications, most commonly for stroke or risk of stroke. And so we have chronic transfusion services that are embedded in our infusion center that is in the hospital itself. But one of the unique things about our program is that one of our providers, Dr. Kyle Mack, has also started what we call the Cooperative Blood Donor Program in conjunction with the American Red Cross in increasing blood donorship among the Black community, so that we can match individual units of blood with patients who with sickle cell disease who require blood to decrease some of the complications that we see from chronic transfusions. We have also been really interested in acute and chronic brain injury in our program. And so most recently, we have developed a collaboration with our neurovascular disease program here at the hospital, which includes a neurologist and a neurosurgeon for our patients who have chronic brain injury. Along the same lines, we have 2 psychologists who we share within with the providers in the rest of the division, as well as a neuropsychologist who conducts neurocognitive testing and evaluation for our patients, who then rely on our educational liaison to help them with their school services. Like many of the other programs that presented today, we have clinical care guidelines and pathways, both in the inpatient and the emergency department settings for both fever and pain management. And then we have a really robust stem cell transplant program that sees our referrals internally from our own program for curative therapies. I just wanted to say a few words about our research mission. We've always had a rich tradition of having studies open here that are both NIH funded as well as industry sponsored. We have some particular areas of interest here, including my own that's focused on exercise physiology, exercise safety, and physical activity for children and young adults with sickle cell. One of my colleagues, Dr. Sharif Badawi, has done a lot of work on hydroxyurea adherence and leveraging mobile health or digital apps to increase or optimize adherence for our especially adolescents with sickle cell who struggle with medication compliance. We have a number of open trials, pediatric trials for disease-modifying therapies. People have already talked about them, crizanlizumab, Oxalitor. And then we have had a rich history of opening studies for gene-based curative therapies here at Lurie Children's, and that's been of interest to a lot of people. Finally, I do want to just do a shout out to all of my other partners who are on this call, because we are all part of the Chicagoland Regional Research and Sickle Cell Partnership called the CRISP Network. And this is part of the American Society of Hematology Research Collaborative. It's a clinical trial network with the aim of accelerating clinical trials, opening up clinical trials for patients with sickle cell disease, as well as supporting a learning community so that we could share knowledge and tools among the different centers who are involved in this network.
Dr. Lin, could you please swap your slide?
Oh, I'm sorry.
Yes. Display settings up there, just click on swap.
Yes. Sorry about that. Okay. And then this slide just shows you kind of a table format of all of our providers here. So we have 6 providers, pediatric providers here at Lurie. You can see here that I'm the program director, Kyle Mack, Sharif Badawi, Christina Berto, who is also board certified in transfusion medicine, Horace Smith, who is a long-standing provider in our program, who many of you guys know, and our nurse practitioner, Stephanie Odenwald. I wish I could say that we have a formal adult program at Northwestern, but we don't. That is a goal for our program to develop in the next couple of years. But I have listed here 2 adult hematologists who specializes in benign or non-malignant hematology, who sees a lot of the sickle cell patients who are followed at Northwestern Memorial Hospital, Dr. Rita Stein and Anna Zachariah, who are both excellent. I've listed here our nurse coordinators, as well as our social worker. We have a community outreach coordinator, a genetic counselor, an educational liaison, 2 psychologists, and a neuropsychologist who we share with the rest of the division. We do a lot of work on clinical care pathways that I talked a little bit about, individualized pain action plans, like many of those who are on this call also adhere to. And we have access to a chronic pain program at what used to be called the Rehab Institute of Chicago, but is now called the Shirley Ryan Ability Lab. We have an adult or adolescent transition program. Right now, many of our adults, young adults, choose to transition either to UIC, sometimes to Rush, as well as to Northwestern. We do screening for stroke. We have school services and an educational liaison, a neuropsychologist. We don't have a parent support group, but like many others, we rely on all of the hard work that Talana has done for SCADI in supporting patients and their families. We have a rich network of clinical research studies, and then a dedicated pediatric infusion center. And then lastly, I was just going to share some pictures of some of our providers. Many of you guys know Dr. Alexis Thompson, who was a longstanding member of our group, who has recently left to go to Philadelphia to become division head at the Children's Hospital of Philadelphia. And that's it. Thank you.
Thank you, Dr. Liam. So are there questions for our affiliate panel? There was one question for Dr. Cohen that was put in the chat. How can you expand on tapering strategies?
So excellent question. So, in general terms, there are some patients who will be on a stable pain regimen at home, have a pain crisis, come in, get acute management, and then very quickly convert back to their baseline program. But there are some patients who need a little bit longer of a taper, where we can have them discharge a little bit earlier while maintaining them on a slightly higher pain regimen as their pain crisis resolves, and then ultimately return to their baseline pain program, individualized pain plan. So the inpatient consult team is going to be working on trying to standardize some of those protocols and get people tapered both optimally and hopefully quickly as well.
Can I say that that question was supposed to be, would you expound on it? But your answer did answer my question, so thank you.
Maybe in terms of what's the best, asking more about the process or about the actual specific ways of doing it?
The process.
Yeah, so basically, the consult teams, basically take someone's, a baseline plan basically, and then based on their inpatient progress, what happens to them, can then modify those. And then what the team can do is to modify those individualized pain plans to include a tapering path, for example.
Thank you.
Are there any other questions? I didn't see any more in the chat. You can also unmute and ask your question directly.
Okay, I've got a lot of questions, but I'm going to try to keep it small here because all of the talks, raise questions with me. I don't live close to any of the sickle cell centers, even though I'm part of Isaac. But personally, living outside of the Chicago metropolitan area, in the outlying areas, I always had to go to emergency rooms close to my house. Now, as the doctor was talking about tapering strategies, I've encountered places that are afraid to give narcotics even to sickle cell patients. And if you have a pain passport, but you're in an environment that is afraid to give narcotics, how do you really, negotiate with something like that? Anybody can answer that question. How do you mitigate that?
I also want to say something too, to piggyback off of Bridget, that you guys are, are all great, and everything like she said is in the city. Bridget and myself both are suburban, and I do travel from the suburban area of Illinois to the city to receive care too. So maybe we can kind of see, like we're collaborating now. It would be nice to see maybe us kind of collaborate out on the outskirts of the city to maybe kind of intertwine some of the suburban location hospitals, because I myself, I do travel from the south suburbs to UI to Rush and UI Health for care. And I've transitioned from both UI Health to Rush. I get care from both because, I am suburban as well. And so it would be nice to have us connect with maybe some of the suburban hospitals.
Right.
Not
And
just you guys, but yeah. Yes, go ahead.
Oh, I was just going to respond to both of your questions, and I'm sure the adult providers have their own perspective as well. I mean, I'm sure that is a huge problem in adult care settings, acute care settings. It's the same. We see the same challenges on the pediatric side as well. I mean, having a pain passport or having a pain plan that you carry with you that's been administered, from your program or your primary hematologist is really the first step. I think the second step is knowing how to get in contact with your care provider so that they can have a direct conversation with that provider in the emergency department. That goes a long way. What I find is that even when we ask patients and their families to let the emergency department provider ask them to actually call us, they don't. They give every excuse, on the sky. And so I always, really empower them to give us a call. Our providers who are on call know to take that information, know where they're going, and then, provide that direct communication and call that emergency department. That works most of the time, sometimes not all the time. Again, there are different challenges depending on the individual providers, individual, emergency departments. I think that when there are emergency departments that we find over again, when there is a problem, then I think that it really is incumbent on us as program directors to reach out to that health system, to really go up the chain of command and to talk about why is it that there are continued problems with our patients who access that healthcare system.
Yeah, I was going to.
You can go to it sometimes depends upon who's on that night or that in the ER, because even within a system that says, oh, there's one system, they put a sign out there, we're not giving any narcotics. They have a sign up. And but even within that system, if you go you get there on the right day, you'll get a doctor who is going to give you what you need, and you're not going to have to negotiate. You're not going to have to, haggle or anything like that, because the knowledge and the practices just vary from one doctor to the next. And I know it's that way in healthcare anyway, but when it comes to protocols for sickle cell and relieving pain, everybody should be on the same page.
Thank you. I believe Dr. Sue had a question. Dr. Sue, do you want to unmute and ask?
Oh, it was really just the same question, just saying that part of what I'm hearing from the other medical centers is that many are using individualized pain plans, and how those are documented does allow access from another hospital, so that's another way to try to answer the question of what do you do in a community hospital.
We also
persuading each ED doc to look is another.
We at the like when I give my patients the individualized pain plans, we also give them a laminated card that's like wallet sized. I actually have them take a picture and put it on their phone so they have it like available, just because if you are at outside hospitals, like you said, there's no, at least there's no sharing. So whatever is electronic may not reach them. So, we've certainly tried that, but like Dr. Leem had said, it has our name on, it has the name, it has the number, it's a 24-hour number. I can't say that I always get calls from the emergency rooms, but our patients certainly have access and they can call us so that we can, speak with the provider directly. But we give them physical copies as well.
Yeah, I was going to sort of second also what Dr. Sue was saying in terms of, sharing, electronic medical records, because the pain plans are helpful as guides. But I also think when an outside emergency room or hospital sees what happened like in detail during a patient's hospitalization at a different hospital, they'll sometimes actually say like, let me follow that. And you'd think they would do that anyway. But sometimes reading narrative, about what happened, I think just reinforces what the emergency room department there should do. I do wonder, someone brought up the idea of how do we partner with these outside emergency room departments, et cetera, and maybe sort of education, et cetera, maybe what we need to do.
Yeah, and that's kind of how I was going. What you guys said about the pain plans and all those things, those are great. This absolutely, but I think my question was more so the collaboration part. How do we connect with the other hospitals on the outskirts of Illinois? I mean, and just not just those, but of course other places too, to make sure they understand how to properly care for someone with sickle cell disease.
I want to add here two things. With the innovation that we have right now and the use of technology, I feel that it should be both ways. So letting the patients know what the plan is, but using the patient portal, I tell my patients to send me a message when they are at a different institution, which may not be able to share or see our care plan, so that I can then make the effort on my end to find out where they are and try to reach to that provider. I know I can say this because ours is a smaller program right now, may not be possible in bigger programs, but I think that sometimes helps the two-way, like not only relying on that particular provider to call you and confirm what the patient is saying. Essentially, that is what it is. They want to validate what the patient is telling them, which is sad, but that's what happens. But me being proactive and saying, hey, where are you? Okay, let me call them there. Who are you seeing? Can you tell me the name of the doctor? And me picking up the phone and saying, hey, I'm so-and-so. Can I talk to this provider about my mutual patient or the patient who's there? That sometimes helps. And to answer your question, Dorinda, the hub and spoke model for sickle cell centers, where there could be one tertiary center, and then there could be satellite clinics closer to where patients are, and then use the tool of telehealth to facilitate care between the local center and the tertiary center, so that patient gets care close to home and still have access to the specialist, I think is the model that might help. And that is why I wanted to look at the landscape of sickle cell disease in Illinois, because you can clearly see where the patients are and where the care needs to be decentralized.
Absolutely. Yes.
I think we need to do the same thing when it comes to infusion centers. We didn't get the 5 million that NASM recommended. I think it was 5 or 6 million for infusion centers. The governor only gave $1 million toward that effort. But oncologists, if you go to practices outside of large universities, and you might have an oncologist who you feel is very competent, but by and large, throughout my life, oncologists do not suggest their infusion centers to sickle cell patients. It's like it's reserved only for cancer patients. And you would really have to push for that. And then you have to battle with your insurance. And things, sickle cell crises are not planned. So that if I need to pre-authorize infusion, well, I have a crisis today and it's not next month that I'm trying to get to an infusion center. So there are a lot of kinks to work out, because you can't look at sickle cell the way you look at cancer, and you can't make it elective all the time the way you can for some cancer patients. So, we've got to have oncologists on board, hematology practices on board with inviting people with sickle cell, and even suggesting it, incorporating into their practice, the use of infusion centers if they have them.
Thank you all for this insightful discussion. We do have to move on, though. We have one more speaker. Thank you to all of the doctors at the affiliate locations for giving your talks. This has been really wonderful and informative. So our final speaker for the day is Talana Hughes, who's the Executive Director at SCDI, and she's going to talk about local services and resources. Talana?
Hi, I'm here. Can you hear me?
Yes.
Okay.
We can hear you.
All right. My screen just went. Okay. Hold on. All right. So again, thanks. And I think that the conversation that was just taking place really, really was an introduction for what I really wanted to touch on. So when it comes to improving and expanding on the fragmentation of access and quality of care throughout the entire state of Illinois, I think the opportunity for the SCIDIC and this Isaac project is a really good example. Hence this summit and all of the discussion and conversation that we're having with the ability to pull together all of the offerings that you all have presented on about. The summit has proven that a lot of work is being done, but the question is, how do we bridge the gap and ensure that the patients and families are aware of all these offerings and that they actually have access to them? As a community-based organization, we always find ourselves in a position of advocating, constantly advocating, and doing our due diligence to be a liaison between and for the individuals with sickle cell disease. Sickle cell does not only cause pain, but a lot of times that's what it's put in a box. That is just, it just causes pain and you just need pain medications to treat it. But we know that it impacts the entire body and long-term definitely damages the body and damages vital organs. It places many of our patients and families in a very vulnerable position. They have many barriers and hurdles that are placed in addition to having a diagnosis of sickle cell disease. To name a few, I mean, transportation alone, just family support, medical team support, insurance approvals and denials, and many, many financial and housing needs that occur. And a lot of times it's due to the multiple hospitalizations and the inability to stay continuously financially stable, employed, or even be able to continue to be enrolled in school if you are a student. I think that this summit is a great example of the programs that work and that the programs that have the funding and the resources in place. But how do we take this? And that's kind of where the conversation was heading towards that we were just having. How can we expand those services and this team approach and this interest and this compassion across the entire state of Illinois so that patients don't continue to face problems such as still being labeled a drug seeker in 2022? For a disease that they were diagnosed with through newborn screening now? Why do we still have patients being mistreated and denied? Why are there still patients that don't know about the current treatment options and even curative options that they may even be able to participate in? And a lot of the things that I'm mentioning are direct questions and conversations that we're having with individuals with sickle cell disease continuously. I know I've heard the mention of community health workers a lot throughout today, but then how do we pull all these community health workers together? Like we have community health workers at the community-based organization. We have two there. We have one in Peoria, Illinois. We actually just had two individuals with sickle cell disease that were trained to be community health workers. And they were all trained through the Sickle Cell Disease Association of America. But how do we then tie all of that into the community health worker programs that we know that are taking place at some of the hospitals here on today's call, but then even some that aren't participating, just so that everybody can kind of be on the same page, but then we can replicate the resources and increase education, and increase the awareness and outreach throughout the state of Illinois. I definitely invite you all, because I know the meeting is basically over, but I really want to invite you all to participate in our monthly virtual support group meetings. We get a very large interaction from patients and families, but it's not only just about the patients and families, but we have the opportunity for providers, social workers, or just anyone else in the community who wants to learn more about the day-to-day interactions and encounters of individuals with sickle cell disease. They are very, very vocal and really share their interactions. I know that on this call, we're talking about the programs and things that are in place, but then what really happens from the patient's perspective? Like, how do they view the programs that were discussed today? And how can we improve that communication on both ends so that the programs that even like we're offering or the medical institutions are offering are actually built around the idea of the care coordination of the patient with them at the center of care? Oh, my screen. Oh. I know that this project definitely has an end date, but I think some of the action that I would hope that could take place is just the continuity and a continuation of us to move forward and continue to move collaboratively for the patients, so that they can continue to receive and have access to care. This was really just the slide I had, and then the other slide that kind of that shows the entire state of Illinois. And this was just to show a bigger picture. I know we had some other maps, but just to kind of show the spread of our state and the many 102 counties that we have, and the approximate number of individuals that we have with sickle cell disease, because we don't unfortunately have a state registry. So I think there's a lot of work that has been done, but I know, and we know that there's a lot more work that needs to be done. Thank you.
Thank you, Talana. Are there any questions for Talana Hughes regarding resources available in our state? There are some thank yous in the chat. Go ahead.
I was just going to say, Talana, I'll look forward to you pushing out that vegetable program that was mentioned. There was something out in the suburbs. I think Oak Forest had something with Black Oaks, and they partnered with them, and they had a farmers market in their outpatient clinic during the summertime. But I don't know. I think that center has since moved to Blue Island. I don't know what exactly happened to it, but that was a nice program because I was curious about it. I went out to see it, and it was pretty good. They had nice offerings. So I think that this is something like that, but I look forward to that being pushed out to us in either by email or through the state.
Oh, definitely, it will be coming out via email. And Dr. Sanders, you can either here, I can drop a link to the website and my email address, so you can directly just refer individuals to our website, because that's where all the information is housed. But then you can also directly shoot me an email if it's someone that you need to have. I know sometimes there needs to be some individual follow-up and just some more questions answered for the patients and families before they participate. What's my email address? Hold on.
Thank you, Talana.
And now I'll drop the link to our website. Thank you.
Are there any more questions for Talana? Thank you so much. So we are going to move on to our closing remarks that Dr. Sue is going to provide. And I'd like to thank everyone for their participation and attendance in today's symposium. Dr. Sue?
Thank you, Patricia. Appreciate it. Thank you all for hanging on after the scheduled end. The closing remarks will just be really brief, that we've heard so many things of progress, of new tools with implementation science, of apps and websites. I don't know if you all saw in the chat that there is a brand new tool, even from American College of Emergency Physicians, that specifically, I can go, keep on going with these slides. Next slide. That have tried to address the needs that were assessed back in 2017, that are trying to implement studies to address them. Next, please. And some of the issues are still huge. How to do health maintenance, manage chronic complications, trying to work on that part still with ongoing projects. Acute complications like pain management, some solutions, some yet to come. Hydroxyurea with an app that is still needing to get wrapped up so that we can introduce it to everybody. Blood transfusion was not really touched upon very much here. Next, please. Isaac has tried to address many of these with the one in the blue boxes, dark blue boxes, and the linkage to comprehensive care is a project about to be funded. We hope to hear any week now. Next, please. And what else Isaac has done is set the tone with more new processes, with more implementation science, with more community stakeholder advisor involvement, more to disseminating information, and also having more trainees and investigators. Next, please. And there is a call to action about what still needs to be done, listed here. The yellow highlights are my own. Those are some of the things that I'm still trying to work on, but we still have more stuff to go. Next, please. Next, please. And if people have to look at a big scale plan, I would like to draw attention to this NASEM report, National Academy of Science, Engineering, Medicine. That's the big call to action in a multi-pronged way, comprehensive, looking at all kinds of things that people and organizations can address in sickle cell care. Next, please. So we do hope for more to come. We'll continue to hold these summits as long as we have energy, and we want to thank everybody. I'm going to pass this back to Beverly or Patricia, whoever's on.
Hi,
Go ahead.
everyone. Go ahead.
Go ahead, Beverly.
Okay. Give me 1 second. Okay, thank you. Thank you to all our speakers. Really was very, very informative, interactive, and very educational. Thank you so much for all that wealth of knowledge that you provided to us today from all parts of the United States. I'm currently in Atlanta, so I'm really, really grateful. I want to first of all thank the ISAC team, who once again, thank you so much for all the hard work to bring this to in Chicago and also CITIC in general. I will also, give me 1 second, let me move to the next slide. We want to also acknowledge everyone that has also worked, current and past team members that have been part of this project in transforming sickle cell care, especially in the Chicago, Illinois region. We want to say thank you and acknowledge you. We also want to thank, first of all, want to thank Dr. Lewis Su, who was very instrumental in the training program in training postdocs and also graduate students through diversity supplements and gaining additional support to be able to work and help and support sickle cell, the mission of ISAC and the sickle cell, improving sickle cell care in general. So we want to acknowledge the trainees as well who were part of this process. Thank you so much for being part of this. We also want to thank, I know Dr. Gaduk mentioned, but I also want to thank Judy Nursek. Dr. Nursek, thank you so much for your remarkable leadership in leading this team and being the program director. Thank you for all the efforts and the work that you put in. I also want to thank Patricia Leslie. Thank you so much, Patricia, for all the hard work and being meeting with us almost every week in planning and the project and leading it on your end. Thank you so much. I also we can't not end this without thanking the work of the advisors that you heard from earlier. Thank you so much for being part of this planning, being part of the organizing team as well. And I'm going to mention names: Maxine Jones, Bridget Reynolds, Dorinda Lawrence Sims, and also Patricia Leslie and Judy Norzak. Thank you so much for all the effort in making sure that this annual summit comes every year. And thank you so much for the attendees that made it here and always register for these events to be part of this and also share it out. So it's on YouTube. Definitely you have the link, and it's on Vital social media. If you want to see the video again, also go on Skadai's social media, Facebook, you will find it there. Thank you so much for attending this and hope to see you next year.
And that ends today's program. Thank you, Beverly.
Thank you.
Everyone have a safe holiday weekend.
Thanks, guys, girls.